Requesting all participants kindly mute your stop your video. Requesting all participants kindly mute your audio and stop your video. Good evening, everybody, and welcome back to AOMSI Web Series. We have Dr. Nabil with us today. We are starting with the Web Series Season 3. Over to you, Pramod.
Praveen,
are you there? Come in.
Yeah, I'm here.
Yeah, play the AOMSI Web Series music, please. Requesting all participants kindly stop your video and kindly mute your audio. Kindly stop your video and kindly mute your audio. Requesting all participants kindly stop your video. Over to you, Pramod.
hi everyone. Please mute your audio and Praveen, hello.
Yeah, Pramod sir, tell me.
Yeah, it's better. That's fine. Yeah. So good evening, everybody. Today we have a very interesting session. I'm very excited because this is something which we not really do, facial rejuvenation, and I think that holds true for most of the Indian MaxFac community. But we have some youngsters who have taken up this field and who are doing some very commendable work in the field of cosmetic and facial plastic surgery. And so we have a few of them as co-hosts in today's session. On the YouTube, we have two co-hosts. We have Sainath Matsa from Chennai. Sainath, do you want to say hi? Sainath, can you unmute?
Hi.
Yeah.
Hello.
And along with Sainath, we have Punit Dubey from Delhi.
Hi everyone.
Yeah, these Sainath and Punit are going to be on YouTube. So anybody on YouTube, if you have questions or any questions to Nabil or questions in general, you can post them in the YouTube chat. The simpler ones will be answered by Sainath and Punit on YouTube chat itself. On to Dr. Nabil. Zoom, we have again three co-hosts. Seema Mathew from Chennai. Seema.
Hi. Hi.
Yeah. Yeah, and we. Arun, do you want to say hi?
Yeah. Hi everybody. Dr. Arun here from Mumbai.
And Rahul from Guwahati.
Hi everyone.
Yeah.
Hi everyone, Dr. Rahul from Guwahati.
Yeah, so on people who are on Zoom, you can put your comments and questions in the Zoom chat window. Again, our co-hosts will bring them up for discussion as and when Nabil stops to take a break, to take the questions. Now we will have Dr. Abhay Kamath who will introduce our today's speaker, Dr. Nabil Fakih. Over to you, Abhay.
I can't get through, Pramod.
No, you're audible.
You're audible, Abhay.
I'm audible.
Yeah, you just.
Good evening, everyone. It gives me immense pleasure to invite each one of you to this AOMSI webinar series 3. And today's guest, Dr. Nabil Fakih, has specialized in cosmetic surgery and facial rejuvenation. Dr. Fakih is the Chief of Department of Facial Plastic and Reconstructive Surgery at the Fakih Hospital. He is the former Vice President of the Spanish Society of Facial Plastic Surgery, as well as the Director of Fellowship Program of the Spanish Society of Facial Plastic Surgery. I welcome you, Dr. Nabil, and I hope we all enjoy this session. Over to you, Dr. Nabil.
Thank you, Professor, for the appointments, and it's my pleasure to start here with all of you and being invited from the Maxillofacial Society of India. It's an honor to me to be here. So should I start with my lecture?
Yes, you can go ahead, Nabil.
Okay, so let me share my desktop. Share screen. So do you see well my lecture?
Yes, we can see the screen. You can go to.
Okay, let me.
Can you turn to the presentation mode?
Yes. Thank you. So
Yes,
today we'll be
perfect.
talking. Yeah, great. So let me just go back. So first of all, as they presented me, I'm here based in Lebanon. So anyone who would like to come join here, this philosophy of facial plastic surgery and cosmetic medicine is always welcome. So in Lebanon, I have 2 clinics, which are mainly, I do cosmetic procedures in them, and I see my own patients. We also have an academy for teaching doctors. And finally, I have a hospital with 75 bedrooms and 40 intensive care beds. So technically at this hospital, we have a fellowship program, which anyone can apply and join this philosophy. As I said previously, I had around 30 Indian doctors between maxillofacials, ENT, and plastic surgeon who have joined a fellowship training at our centers in Lebanon. So anyone also would like to follow me, he can follow me at Instagram, which I share a lot of information, which are medical information. It's not only a page for my patients, only for other colleagues, which they can see in and dip in surgeries. So today I'll be discussing about 2 things. First is toxins, and then I'll be discussing about fillers. So, and in fact, I'll be discussing everything, and everything means everything that it comes to your mind and it will pop to your mind. I will be discussing it and to try to let you teach you the steps, how to start to more advanced. So first, starting with botulinum toxin, I'll be talking about planning and the tips and tricks whenever you inject in every area. And then we'll divide the next lecture would be about fillers, about how we inject every area, the complications that we can have, the treatment of complications, danger zones in every area, and advanced techniques. So let's start with planning and knowing about toxins. So if you don't know about toxins, what they do, exactly what we do is whenever we put the toxin in the skin, what will happen that it will inhibit the neuromuscular transmission by blockage of acetylcholine release. So the acetylcholine release will not be able, since we block this, and by that reason, the muscle will not contract. So it would be simple just to explain things simply so you can everyone know more about things. So the next thing is in every toxin, it's a complex chain. And in the chain, we have light chains and heavy chains. And in between the light chain, which is the purple, and the heavy chain, which is the blue, we have, as you could see, non-toxin proteins, which as you see, they are called HA and NT and H, which is all hematoglobin or non-hematoglobin. And as you know, this complex that we have in the toxin, we can really see that some of them in the market, they have toxin, they have proteins, and other they don't have proteins. As you see that Xermine, which is from Merck's brand, does not have any complexing proteins, whereas Botox and Dysport, another two brands, they have in between complexing proteins, which is the brown here. So that means that Xermine is the only toxin in the market that does not contain complexing proteins. So also something else which you have to know, botulinum toxin needs to be at a storage temperature between 2 to 8 degrees, whereas the only brand that does not need refrigerating, which is, as you could see, Xermine from the company from Merck. So you can put it at room temperature. So talking this, what's the advantages of not having a complexion protein? Then it means that you have less possibility of creating antibodies and resistance. Great. So let's see how I plan to inject toxin. So for planning, you have to know two things. One thing is to know that we have muscles that are elevators of the eyebrows, and we have another muscles which are non-elevators. The elevators is the frontalis muscle. It's only one muscle, but the non-elevators muscles or depressors are the orbicularis muscle around the eye, the corrugator muscle, which I'm signaling here, the procerus muscle, and these muscles will reduce the eyebrow. We have also another muscles around the nose, which is the nasalis muscle, which sometimes can make the bunny lines, which we are discussing in the upper part of the face. So see, I will tell the patient to contract her corrugator area, and I will mark the center of the procerus muscle, which is, this is the muscle. I will put a toxin, a dot here. And then I will draw the corrugator muscle, and I will be putting the two dots, one at the front head and one on the posterior head. And by this, I'm paralyzing the procerus muscle in the center and the corrugator muscle at the lateral part. So normally I use 4 units in the center and 4 units at the first head and 2 units at the lateral part of the corrugator. And I will explain later why I use less unit on the external part. But also, as you see, I'm drawing red and yellow. Red means that they are deep inside the muscle, whereas yellow means that you are, in fact, half midway, not too much deep. Deep, it could be reaching the bone a little less than touching the bone in the muscle and deep, whereas yellow is half midway. And I will explain later why I'm going half midway. So the next step, I tell to my patient to elevate her eyebrows. And when she elevates, I will draw 2 lines, which is the maximum elevation of the eyebrow. So we put toxins, the lateral part, the maximum lateral part is with maximum elevation of the patient she has. I will draw a line. Also, I will tell the patient to draw to continue elevating her eyebrow, and I will leave 1 finger from her eyebrows to this line. I put 1 finger. So then I will have this drawn, and then I will be marking my points. So the first point is exactly in the transaction or a bit higher, depends the patient's starting wrinkles, but technically is the first point and the maximum lateral point I need to inject. And then in between, I'll be injecting, as you could see, several points just to continue filling. Some people need to inject 2 lines, and some people need to inject 1 line, depend how much wrinkles we have. Remember something, that every dot we have here, the diffusion of the toxin is of 1 centimeter. Then if you can assess a 1 centimeter fully receiving all the area, then it means you need 1 line. Remember that these are green, which means extreme superficially injection, okay? Subcutaneous injection, okay? Superficially to the muscle. So remember something, so in the face, knowing all the areas that we need to inject, take a picture of this, because where you see green means it's superficial, and when you see red means that it could be deep. But I will be explaining this later. So again, some patients, as I said, they need to have 2 lines, and some patient has only 1 line. So in case patient has 2 lines, I can add a bit of 1 unit on the maybe I add 2 units also on the second line. So again, I said the maximum lateral toxin would be my maximum eyebrow elevation, and exactly my maximum starting point is where exactly over the line or on the line. So for this area, I would go always with 4 units in the upper eyebrow. Why? Because I want to really relax all the orbicularis muscle contraction, so the eyebrow can go up. And then I would be putting 2 units in every one here. All are superficial green. They are not red, green. And again, sometimes I have to put 4 dots because the patient has longer distance from eyebrow to the eyes. Sometimes I have to add 1 unit here to relax the patients, and sometimes I add another unit more medial. This do not have fear of putting toxins here. We have a very powerful muscle, the orbicularis. It can really handle a lot of units. You can exactly put 2 units here, and nothing could happen only except relaxing this part. So you can start with 1 unit as a starter and only 1 point, but when you can get more advanced, you can really add another point more medial. And sometimes you need to add 4 units on every side. As you can see, all are green, which means superficial, okay? And the units are inside the circle, and we can put at both lateral sides to eliminate the bunny lines that we have. Then again, this is another patient. We elevate her eyebrow. We don't put toxins in between here superficially, only deep, as I said, or half midway, just to inject procerus and the corrugator muscle. And this is like the way we can reach in any patient. You can take a picture of this. Remember this, that this is the map for the upper part of the face. Okay, so this is, as many of you, they told me that your starters and toxins maybe. And again, what I have to tell you that, remember that you start with the upper part of the face, and then when you become more advanced, you can start injecting toxins for gummy smiles, for masseters, for pain, for asymmetry, for nasal flaring, for chin dimpling, for other options in the face, which we can really discuss. So let's start with the 40 tricks and tips. So first, for mixing and preparing a reconstitution. So first of all, everyone who wanna mix toxin, depends it's 50 units or if it's 100 units. Remember something, that in 50 units, you need to put 2.5 cc of saline. And in 50 units, you have to put 1.25 cc of saline. And this is what book says, and this is what the majority do, and this is what is totally wrong. You have to put a bit more. You have to put 2.6, and in the 50 units, you have to put 1.35. You tell me, why, doctor, you're putting 0.1 more than the other doctors do? And I add 0.1 cc more of saline, and that's because in the needle, you will lose 0.1 here. So then if you're not putting 0.1 additive to the unit, to the mixture, then you will not dilute exactly the 100 unit on 2.5 cc's to have exact measurements. Always put a bit more. The second thing, also, you can mix the toxin, as you know, with saline. And if the patient feels pain and you want to reduce pain, you can use bacteriostatic saline, which has a pH more neutral. And then when you mix the toxin, the patient feels less pain. But also, if you want to really have less pain and the patient cannot tolerate, you can mix the toxin with lidocaine. And I have used a lot in many of my patients who are very sensitive. I put lidocaine in the toxin, and I put exactly 2.6 in 100 units or 1.35 in 50 units. This is a study published in 2013. There is no increase in adverse effect and no decrease in pharmacological potency, and immediate feedback to the clinician and higher satisfaction rate of the patient. So mixing lidocaine with epinephrine and toxin, they say, and the study seems that the increased duration a bit more, some weeks more, and the onset is much faster. Third point is this. It's very important, if you are injecting toxins, to open the bottle. You need to open the bottle, because if you don't open the bottle, you will still lose some units inside. And we open the bottle for not leaving any remnant left material inside. Tip or trick number 4 is, I don't use the insulin needles at all. Insulin needles are from old era. If you're still injecting toxins with insulin needles, you need to update yourself and you need to move to the new generation of toxin injection, which we use the invisible needle from TSK Labs. So this is a more smaller needle. It's a 33 gauge plus, which means it's a 34 in fact. But the most important thing, that has loaded space hub, and you don't lose material in this hub because it has a very loaded space hub. So exactly you will have, if you mix 3.6 in 100 units, sorry, 2.6 in 100 units, or 1.35 in 50 units, you will really receive the correct dosing for the patient. Great. So let's go now for the 36 tips evaluation points. And this is very important because here you have to really know exactly what we are talking about. And the first thing is to know that we have two options of fillers. We have fillers that diffuse more, like Dysport, and we have fillers that diffuse less, like Botox or Xermine. So in India, Dysport, Botox, and Xermine are available, as I know, and then it depends where to use. So in fact, I don't use Dysport on the face because Dysport diffuses too much and can create more freezing effect because diffusion is more, but also you can have more incidence of complication if you inject wrong because diffusion is higher. Where Botox or Xermine has more concentrated 1 centimeter diffusion and it's more precise. So for the face, I prefer to use more botulinum toxin or Xermine, whereas for the body, you can use for sweating forever Dysport. As you know, I'm key opinion leader for MERS aesthetics, so I only use Xermine for everything. So the first thing you have to know is to evaluate the patient's asymmetry. And please document, take photographs, and inform patients about asymmetry. Because it's very dangerous that you can have a possibility of exacerbating the pre-existing liptosis, maybe because the patient had, and she comes back telling you later that you have created this with botulinum toxin. Please tell your patients what they don't have asymmetry before doing any procedures in cosmetic plastic surgery procedures. The next thing is, remember something in people who have hooding, beware. These patients who have hooding, you have to really take care a lot about what they really have. Because patients who have hooding, please do not advise to start with toxins, except if he accepts that if he wants to inject in his frontalis muscle, the eyebrow will collapse down and they will be feeling that they have more droopy eyelids. Then these patients, I try to advise them first to do surgery. Let's do a blepharoplasty surgery first. And after this week, the Botox will become better and nicer. And if she doesn't want to do surgery for whatever reasons, you have two options. Do not inject the frontalis muscle, or tell her, if I inject your frontalis muscle to reduce wrinkling in the frontalis muscle, then you have to accept that your eyebrows feels more heavy. The next is evaluate orbital tone. In these patients, you can really try to do the touch test, or which is you press slightly on the zygomatic and ask them to smile to evaluate the wrinkles. If you see that the wrinkles are very deep, please do not promise your patient that toxins will help them. Then here you need to do fat grafting, you need to do fillers, you need to do laser resurfacing to improve these wrinkles. Beware and evaluate static brow. Some patients has higher eyebrows, other has curved, other has straight. People who have higher eyebrows, results of toxins are much nicer. People who have low eyebrows, results of toxin is not so much enhanced. And this is very important because the architecture of the eyebrow creates a very impact result to your friends' patients when they see that the toxin has improved them too much or less. The next is evaluate the position of the frontal points. So it's very fundamental to know something that these frontal points that we have here require sometimes not to go too low, because if we inject too low, the frontalis muscle will be paralyzed in the lower part. So we need a bit of muscle to be active of the frontalis muscle so we can have really a small tone taking care of not drooping too much the eyebrows. So we draw this line I've explained before, and we put the toxin over this line. So also beware not to forget in people that you have to put 2 lines, because if you put only 1 line, the patient can come at 2 weeks and he has wrinkles in the upper part. It's not a big problem because you can solve it injecting more toxins in the upper part, but it's not nice that the friends of them, they will feel that there's something wrong in their forehead. And this talks about a lot about your quality and how you are precise injecting toxins. So you should always plan and think that it's 1 centimeter diffusion, and if it really covers the 1 centimeter diffusion, then it will cover these wrinkles. If not, you have to put another line in the upper part. The 7th point and the most important point: evaluate low short frontalis muscle. This is me with a very low short frontalis muscle, and this is very tricky in these patients. Some people come to your clinic and they tell you, hey doctor, I have low eyebrow and I don't want to put me on my frontalis muscle, and also I don't want to put in the frontalis muscle because it will be more expensive, so I want less toxins. I only want around my eyes and in the corrugator area. So beware in patients who have low short frontalis muscle insertions. Please do not offer this treatment as they say. Tell them that you can do this treatment. You are obliged to do full toxins in all the areas, in the frontalis, in the corrugator, and around the eyes. And why? Because if you put around the eyes, what will happen that you will create a false Mephisto effect, creating my eyebrows to contract upper in the corners and here have all this area paralyzed. So it will be very awkward effect. And I tried it on myself because it's very hard sometimes to find people with short frontalis who will accept this. So I can have it in a lecture and teach others not to do it. So also that it can happen if you really put toxins wrong, you can create also real Mephisto effect. And this is doctors who really read some old books. And in the old books, it say that you draw 2 lines in between the eyebrows, the iris center, and then you pupils, and then you put toxins in between these lines. Please beware, do not do this. You draw the line exactly what is the maximum elevation of the eyebrow, and here you start putting your toxins. Do not put toxins in between the pupils, as old books says in several books I've read. Please be updated. We draw the line where is the maximum elevation. Some pupils would be with maximum central elevation, but others will not be. So beware this and try it exactly where is maximum elevation of the eyebrow. Remember something, that if it happens this complication to you, it's very easy to solve. You put 2 units exactly in the maximum elevation where it's contracting, and then it will release and relapse. Beware in patients who are old and they have too much wrinkles, or men who have wrinkles very near the eyebrow. You are obliged to put some toxin here if you want to relax these. But it's better these wrinkles to treat them with fillers and tell to the patients that you should put less toxin material here, but they will not be able to elevate too much if they want to correct these wrinkles. Beware, and when I say beware, it's beware. 50% of people who become over 50 years old, they have lacrimal gland prolapse. And I've seen a lot of lacrimal gland prolapse. I do a lot of eyebrow lid surgeries. And I've got a lot of surgeons coming to me as, Stuart, maybe you know him, Priyanka, Rahul, Dr. Arun, Panda, all these doctors who join me here, Deepak Khanna also. They have seen that the lacrimal gland, it prolapses. And when it prolapses, it's very tricky that when you inject toxins here, it diffuses till the lacrimal gland if you are injecting a bit deep. And this diffusion will create dry eye to these patients. People who have lacrimal gland, try to avoid, go more laterally, or try to be very superficially and putting less quantity. The second thing, evaluate low corrugator insertion. Some people's corrugator could be inserted going upwards, and other people's corrugator is inserted exactly over the eyebrow, as we could see in this image, in the lower part on the left side. Remember something, that you have to maintain 1 centimeter if you want really to inject with safety. But sometimes you can push yourself and go more near if you know and you are an experienced injector. So remember something,
Yeah, Dr. Amit, are you there?
Hello.
Yeah, he told
Dr.
me
Nabil?
he's
Yes,
back.
sorry. Yes, I'm
Yeah.
back. So
Yeah. If you
let
can
me share
repeat
back.
2 minutes back. Yeah.
Yes. So I was here exactly.
Yeah. You were. Yeah. Just start of this. Yes.
Yes, and as I was explaining that in these areas, beware not to inject very deep in the yellow areas, because if you inject deep in the yellow areas, what will happen? The fusion of the toxin will happen, and the toxin will go downwards to the eyebrow, and under the eyebrow we have the elevated papularis muscle, and the patient will have an eyelid ptosis. Remember something also, that patients who are very thin skin, they don't have fat, please do not inject the other point, this point. So only inject the first point. And why? This is a patient which I injected twice on hair toxins. And the twice on hair, I had eyelid ptosis. And I've said, why did I have eyelid ptosis in this patient? I'm experienced injector. I knew that I was very safe. And why it happened? It happened that patients who have very thin skin and they do not have too much fat, their bodies is skin and bone and muscle. These patients injecting in this part, since they don't have too much fat, the fusion is very easy to reach the elevated papularis muscle, and ptosis of the eye would be very easy to reach. So please beware in these patients, only inject this point and avoid the third point. So why it happens? See, it happens because exactly what happens, that the toxins, when you inject it up, it will reach this muscle. And when it reaches this muscle, the elevated papularis muscle, which is the pink one, it will paralyze. So the eyelid will go down and we have apoptosis in the eyelid. Remember something, that under the elevated papularis muscle, we have another muscle, which is the green one, which is in fact, the molar muscle. And this molar muscle is a helper for us. And I will say why. So remember something, that technically, every injector, if he injected in his life, he will have a percentage of eyelid ptosis. If till now you didn't have any eyelid ptosis, this means that you didn't inject it too much. When you inject too much, you will start having, and it's normal to have in your career, between 5 patients to 10 patients, depends how much you inject. So tell your patients, always advise them and be prepared for this event if it happens. So what you should do if it happens? If it happens, you have 2 options. Option number 1, to use iopidine drops. These iopidine drops are, as you could see, and an option, or you can use Nafcon A, which is another option. In your countries, you have to see if you have these medications or not. So as you can see, what is iopidine? Iopidine is alprazolinidine 0.5%. It's a treatment for glaucoma, and what it does is augment the tone. It causes the molar muscle, which is the green muscle under the pink muscle, the elevated papularis muscle that we described before, to contract quickly, elevating the upper eyelid, around 1 to 3 millimeters. So how many drops we use? We use 2 drops every 8 hours, and it's only in the affected eye. So this is very important to know and to remember, that only in the affected eye, we need to inject this toxin. So we continue that some patients, and it's published in 2015, could have apoptosis that could result in up to 13 months. Mainly the majority will resolve between 4 to 6 weeks. And using iopidine will improve the patient. It's not the best, it's not the saver 100%, but the patient's improvement in the eyelid opening improves. And whatever it improves, the patient could feel less anxiety. It's always anxiety for the doctor, because he has to accept the patient, to call him, to write him, to whatever, that the eye is still like this. And normally it results in 4 to 6 weeks. But there are some people who are not responders and can take up to 13 months, and it has been published. So beware, if it happens, this is a possibility. So everyone who want to have a wedding, please avoid treating them. This is a patient that he came to my clinic and he wanted to do toxins. I refused to do the toxin. So he went to another clinic and they injected him toxin and he had an eyelid ptosis. Then he came to my clinic if I can help him. So beware, people try to avoid, also avoid 2 weeks prior to any important event. So not to risk it. It is the best day of his life. So let him be happy for this day. So second is evaluate droopy eyelid ptosis in patients who have it. Some patients come to my clinic and they don't know that they have a droopy eyelid. They said, oh, I didn't know this. I thought that my eyes were like this, or because of my eyebrow are different. No, you have a medical problem that you have an eyelid droopy. So beware, inform the patients, because some people could say, if they don't know him, maybe you did toxins and you have a droopy eyelid, or maybe they will say that he has a problem after you injected toxin. Beware and evaluate, in fact, the lateral part of the rim. So these areas, try not to be too inside the eye, because diffusion from the lateral orbit to the muscles of inside the eye can create diplopia. And always stay 1 centimeter away from the orbital rim and inject very superficially in this area. Some people you need to inject 2 lines, as you could see, and whenever we want to inject 2 lines, because they have more wrinkles reaching the ear or the hair, and they have a powerful muscle, and we need to really paralyze all the muscles around the eyes. Beware in patients who has infraorbital fat pads. These patients avoid injecting a toxin in these muscles here. Why? Because the pretarsal drift causes temporary eye bags. And if a patient has a weak orbital septum and excessive skin and fat, and you inject toxins, the bulgy fat will appear to be more. Evaluate laxity by doing snap test. And if you don't know what snap test is, I tension the eyelid lowerly and to the floor and try to see how it snaps up quickly, backwards, upwards. And the eyelid distraction, I take the the skin from here, I distract it to myself, I distract it to me. And if it distracts more than 10 millimeters, that it means that it has a very weak laxity eyelid. So beware in these people, they have more potential of developing ectropion, and avoid injecting toxin in these muscles under the eyelid, because we need the muscle to support the ectropion. Regarding some people who come to my clinic and they have this hypertrophy of the muscle in the orbicularis lower part, and this is not fat, this is not eye bags, this is the hypertrophy of the muscle. These patients who have hypertrophy of the muscle, they are good candidate to put toxin in every muscle, and by putting toxin in this muscle, it will relax the muscle and it will widen the opening of the eye. And I will show you cases in the later stage when we talk about fillers, combining them with fillers. Beware whenever you inject regarding the vessels that are around the eyes. These vessels around the eyes, if you really inject in them, you will create an hematoma. And remember something, you're treating cosmetic patients. Cosmetic patients, they come to your clinic and they have the money to pay. Then you should really attend them very unique, very special, and really they should be treated as unique, because no one wants to go there to become beauty and beautiful or prettier, and then he has an hematoma around his eyes for 2 weeks. So you can use the Akia vein machine or loops, or your own vision, contracting the skin and seeing where there is veins, and try to avoid to inject in between, because no one wants to have an hematoma. So second thing, and it's very important, and maybe one of the most important slides, patients who really have something, hollowness in the tear valley. This area we call the tear valley, and the inner part we call the tear trough. People who have hollowness in the tear valley, please do not inject toxins. Why? Because when they smile, they will create a very, the cheek will not contract up and the cheek will maintain down and giving a very awkward smiling. So if this, what I tell them, please put fillers first, and when it's filled, I can put toxins to improve your wrinkles. People who have good filled area, you can put very well toxins here, and you can go a bit more down, And by this, you can really improve the wrinkles there. Why? You see, if you put your finger and she smiles, if I relax this muscle here, the cheek will collapse down and will give an awkward feeling. Evaluate the height of the tail of the eyebrow position. Very important at this point. I usually use 4 units here and 2 units up. And why I use this? I want to decompensate this balance in a way that the muscles that contract downwards to really relax much more than the muscles that elevate. So it will always have a more effect of elevation because we have less paralyzation here and more paralyzed in the lower part. And this is one of the things I like too much, to use the 4 units at the tail of the eyebrow. It really pops up the eyebrow to get a bit of elevation upwards. So very important in people who have too much wrinkling, and I call it the extended wrinklings. For patients who are extended wrinkles, for sure, fillers, injecting some fillers, some radiase, some calcium hydroxyapatite here can improve them much more, and maybe some fillers superficially can reduce the wrinkles. But also sometimes you can put some toxins very superficially in the lower part, very superficially, extreme superficially. Beware not to go deep, because you can create paralyzing the zygomatic nerves and the lip will go downwards. And try just to be very superficially, and sometimes I put a lot of points here to relax the muscles a bit. So the second thing is, in case you inject deep in these muscles that you want to relax, then they will reach the zygomatic muscles, and caution, you can have, as you could see, a paralysis in the lip. The patient cannot elevate his lip. Remember, whenever you inject the bunny lines, if you go very near the rim of the bone in the maxilla and not going in the bone of the nose, half midway the bone of the nose, the diffusion to the muscles will go downwards, and the diffusion will go downwards and outwards, and what will happen is a droopy corner of the mouth or lip ptosis. So beware this area when inject your bunny lines. Be in the bone of the nose, in the muscle. Try to be superficial and half midway in the bone of the nose, and try not to go inject downwards or outwards. The evaluation number 26 is to really evaluate the socket of the eye. So you can do the pencil test, which is, it checks the skeletal support of the lower lid. And if the pencil is very close to the cornea, then there is a great risk of infraorbital content bulging, and beware whenever you inject toxins in the lower part of the eyelid. Here again, very critical. Every injection around the nose, you should avoid inject outwards, and you should inject in very small doses and normally very deep. And why I want deep? Because I don't want really to paralyze the orbicularis oris muscle, because if it paralyzes for whatever reasons, injecting toxins in the tip of the nose, downwards here to elevate the nose or whatever, if you inject superficially, the paralyzation of the upper lip will happen. And if it's paralyzed, what will happen? It will have an awkward smile of the patient. Also, beware injecting toxins in these wrinkles. I've seen a lot of doctors that inject toxin here to relax the muscle that are contracting and creating the coat bar in the lip. And it's wrong. You should never inject here. You should inject exactly in the verbena muscle, very superficially, and this point will diffuse exactly to here and will paralyze the muscle. If you inject up in the middle, the muscle will be paralyzed too much, and the patient will have really a very awkward smiling or kissing whenever he kisses. So the next thing is, and it's very important, is whenever we inject the depressor oculi angularis oris muscle, it's my favorite point to inject in patients because it has a tremendous effect on the corners of the lip. And technically, in 99.9% of my patients who I do fillers in the marionette lines, I add to this area toxin. Why? The result becomes more impactful. And what I do is exactly, I tell the patient to smile and to make like he's sad. And exactly, I draw a line from the sadness to the jaw. And where the wrinkles happen in the center, exactly. And in contact with this line, I drew the black line. I'll be injecting my toxin half midway. It's yellow. It's not green. It's not red. It's yellow, which means half midway. I'll be using between 2 to 4 units, and it's here. Beware not to inject more medially, because more medially we have the depressor labiae inferioris. And if you really hit this muscle, which is below the other muscle, what will happen? Apoptosis in the lip, and the patient, when he smiles, he cannot contract the lip downwards. So beware whenever treating these patients. The chin. Last week, I had a patient which she did toxins in another doctor, and she came to me that when she smiles, the lip everts inside, and she could not evert her lip. And when she smiles, it dipped inside. And this is why happened. And she came, she was very upset. So she went to her doctor. The doctor told her that this is the way she smiles. She knew that this not was the way she smiled. Maybe the doctor didn't have all the knowledge regarding this. And technically, because he injected a bit high and he paralyzed the orbicularis muscle. So if you paralyze the orbicularis muscle, you will have this problem. You have to paralyze the mentalis muscle. And the mentalis muscle is deep and in the lower part. It's never in the upper part. So beware whenever you inject up high, beware just diffusion of the product can happen to this muscle. So always stay deep. If you want to really be safe and you don't want to really inject too much, just inject 1 point in the center and low. And by this, you can start doing this technique. And when you become more expert, you can start injecting more points and 4 points and whatever points you need. For the neck, limit injection to the platysmal band and avoid high doses in thin skin, because you can create a lot of fluffy neck syndrome, or if you diffuse to the center, it will create dysphagia and dysphonia. I never had any case of these, but I have a patient who injected to a famous singer, and the singer could not sing for 3 months, and he had opened him the case, and finally he won the case because he could not do his music and whatever he needed to do this summer. So beware in these patients what you offer. If you are teachers, singers, whatever, you can limit their function of life. So tell them that they have a chance and try to avoid to inject in the center. For the masseter, it's very important. It happened to me. Maybe a lot of you inject in the masseter, and the masseter you have to inject only 3 points. This point, and this point. Avoid this point. And why you have to avoid this point? You should avoid this point because the resurreus muscle is inserted on the lateral part of the masseter muscle. And if you inject here and it diffuses to the resurreus muscle, the patient, when he smiles, he could not take his lip more wide. He cannot create a wide smile. So what happened to this patient that when he smiles, it was a very little smile. So this patient happened in a unilateral with me. So I learned that you should avoid to inject this because the resurreus muscle is there. And beware in these patients just to be as back as possible and drawing. So I draw the muscle, and when I draw the muscle exactly where it is, I target the 3 points and sufficient. You can put 4 units, and sometimes you can go for a 4th point more posterior or in between the red point and the green point, just half midway. And you can add more units if you want, like 5 units in every one. Then it depends on the power of the muscle and if it's men or woman or what's the problem. So also in patients who do the first time toxin, it happened to me. The first time I did toxin on myself, I had headache for 2 weeks. So why that happened? So the next time, the 3rd time, I was very feared, and I just injected without taking any pills, and it didn't happen anymore. So some people who start doing toxins the first time in their life, they can happen with headache as a 2 weeks headache, and they need to take anti-inflammatory. So young people who come for the first time, or people who do toxins for the first time, always prescribe anti-inflammatory to take for 2 weeks. In case it happens, you're covered. Evaluate the level of wrinkles. Be realistic with these patients. Some patients come to me like this. Hey, doctor, they told me that toxin can fix my wrinkles. No. You need to tell the patient, to explain the patient, static wrinkles cannot be fixed with toxins. Dynamic wrinkles can be fixed with toxins. Static wrinkles need fat grafting, fillers, lasers, or whatever. So it's very fundamental to discuss with the patient what exactly you need to do. And one of the other tricks you can sell in the clinic, and it's available in India, is from Zero Skin Health, a cream called growth factor serum. And the growth factor serum, I call it at the Botox plus additive. So in the clinic, people can do toxins or can do toxins plus. And toxins plus means that he do the toxins and he take the creams to use at home, because it have seen in a study that it reduce the wrinkling and improve the wrinkling at that area. Beware of neurotic patients. I have a lot of patients who come to my clinic and they ask me very things that could not happen with toxins, and they assure they have read it and they know about it, and one doctor did it for them and it was perfect for them. So beware these patients who are neurotic patients, careful who talks about other doctors or high procedures or with depression. Anyone who I feel he is neurotic or he hide any procedures or I feel he's not good, I try not to do on him anything. If I see that the patient, I can control the patient, means that he obeys what I say, I can push myself to do it because I can control his mind. But if I see that it's impossible to control, he's undownable, then it's better to say that you can't help him and better to let him see another doctor. Thank you so much for the toxin lecture. So we'll jump for the questions about toxins and about anything related to toxins and to
Yeah, Dr. Nabil.
Yes.
One of the participants has asked, it's a very simple question. He is asking, can you give analgesics after the Botox treatment?
Yes, I can give analgesics, as I said, in every patient who is young. The first thing that can happen to them, so I always put analgesic to them. I just prescribe.
Okay. And
hi, Dr. Nabil. It was a good presentation, excellent. There are some questions that the participants have asked. They've asked, is there any complications of injecting Botox other than the things? Is there any allergic reactions that they can look forward to apart from the headaches?
So technically allergic reactions for toxins is very rare, and it can happen with the proteins of the toxin. That's why I use Xermin, because they don't have proteins. So incidence of any allergic is much impossible. In medicine, there's nothing impossible, but barely impossible. And the other thing that does not need refrigerator, then you can go from clinic to clinic with your toxins. And the third thing is that with this toxin, the incidence of creating any antibodies formation and resistance is extremely impossible. So again, I'm not telling you to use this brand. I'm telling you scientifically what this toxin is maybe for. I think it's better than the other. But again, as everything in medicine, you choose what to use. And I can tell you what things are important and scientifically proven. So regarding other complications, some people can read that some patient can die with toxins, and how toxins started in that age. The United States wanted to kill the Germans and Hitler and all these people, and they wanted to put toxins in the gas, and they smelled this gas and they paralyzed their lungs and they died. Technically, to kill someone with toxin, you need 5,000 units to kill someone. So we use very little doses, 100. My maximum patients I use on him is 1,000 units for migraine. It was injecting 1,000 units in frontalis, in masseters, in pterygoides medialis, in occipital, in the muscles of the neck, in the temporal, and in the cosmetic part also. So all this, I can paralyze all these muscles to really give a very nice relaxation of the muscles, and the patient could feel that they don't have migraine. I used 1,000 units. So technically, to kill someone with toxins, you need 5,000 units, which we never reach. We never do that in cosmetic.
Dr. Nabil, there's one more question. Once you dilute Botox, for how long can the viability of Botox remain? How long can you use it for? Suppose if you don't finish it in one patient.
So in fact, normally, as the bottle says, or the company says in the box, it says for 2 weeks you should leave it in the refrigerator. But I can tell you something. I tried to leave for 1 month. outside the refrigerator with Exermine, and it worked. So technically, that's something that you should really consider as a maximum of 2 weeks for 2 reasons. Keep it in the refrigerator for avoiding bacteria growth in the toxin if it's open, which one thing I did is to try it, but doesn't mean that I'm doing it to the patients. And the second thing is you leave in the refrigerator to maintain stable, as it says the company.
Dr. Nabil. Yeah. One thing is in India, we have a brand called Alpha Drops 0.5%, which is aproclonidine, and which is used for ocular hypertension. So we do not get iodine here. So we get something called as Alpha Drops 0.5%. That's number one.
Yes.
Okay. The second thing is there was a query that could there be antibodies formed against botulinum toxin?
Yes, antibody formation of with botulinum toxin can happen, and there is articles published regarding this. You can read them. If you need them, I can share them. So that's why reason I have shifted to use only Exermine for securing this option. Whatever, it's very rare. The incidence is 0.01, which is rare. But again, as you want, if you have options to use something that doesn't have protein, you can use. So regarding the aproclonidine or iopidine, you should use something similar in medication to these, because they have seen that these two medications recommend use iopidine. And for that reason, if you don't have it, if you travel everywhere in the world, you can get it. And in Lebanon, we don't have it. And when I travel to Spain, since I have a home there and I'm originally born and raised in Spain, so I can get my iopidine from Spain and have a stock in Lebanon. So if it happens to me, then maybe you have been in my clinic and you have seen how much toxins I inject and how much fillers I inject. It's barely crazy how much we inject. And I had, in all my career, I had only 1 complication in fillers and 5 complications in toxins. It's much easier to have complication in toxins than in fillers, because I can say that errors in toxins sometimes could be more in percentage, but the incidence of complication in fillers is more dramatically. Heart complication can happen, which can really make your career to be have a good penalty on your career and not work anymore. But with toxins, you wait, you come back to where it was. Something I should tell you, I recommend to get iopidine for everyone who will do toxins, because in case it happens, I mean, it can make you not to sleep for several days. And if it happened to you, you see how much stress you become. When you become an experienced surgeon and you have credibility, then the patients normally respect you too much. If it happens a complication, also you are more saved, because your reputation creates for the patient to go more understand. But if you are not known and it happens a complication, patients will directly attack you. And again, colleagues will not credit you. Yeah, this doctor did. And you know how sometimes colleagues are bad with these things. And that's why I always think that reputation, whenever doing something, it's a saver sometimes for several complications that can happen to any doctor. I have complications as any doctor has. And if you don't have complications, means that you're not doing surgeries, or you're not doing toxins, or you don't do fillers. If you do, then you should have.
There is another query from my side. So I had a patient for whom I injected toxins, and it worked for the first time, and the second time and third time, it doesn't work. So I was a little surprised, and I started looking out for the answer. So could you just elaborate us something about the primary non-responders and the secondary non-responders?
Yes. I think, are you seeing my lecture now? You seeing my presentation?
No.
Okay, I should share it. Maybe I should share it now. Let me see how I share my presentation. How can I share my lecture now? Give me 1 second. Anyone can help me so I can share my lecture? I'm pressing over.
You need to open it first. Yeah.
Okay, I see. Share screen.
Yeah,
Okay.
Yes.
So as you see my screen, the question you asked, Dr. Arun Panda, is maybe one of the most important questions that you've asked, because very little doctors know about this. There's a phenomenon called sprouting, and sprouting means something that you should know. Whenever I inject toxins, in fact, the connection from the neuron till the muscle is blocked. So the information cannot pass to the muscle. If the information cannot pass to the muscle, in 48 hours, the body creates legs. These legs that the body creates are called sprouts. So at 48 hours, the body creates sprout tool here, at 1 month here, at 2 months here, at 3 months, the body creates sprouts to here. So what happens at 3 months? These roads are leading some actions, so the muscle is contracting, but still here, we're not contracting. That's why toxins last for a certain time, and the patient can tell you at 3 months, oh, doctor, the toxin has went. No, the toxin did went, but there are some muscles are starting to move. What happens at 4 months is that the body goes up, the sprouts goes up. The body says, okay, now it's working the muscle here, and some of the actions here are open now. There is no more blockage, and some muscles are contracting here because of the elimination of the toxin. And then the body says, okay, the muscle is working. Let me take out the sprouts again up. So you take the sprout up at 4, at 5, at 6. That's why we have to do the toxins every 6 months. Why happens in your case? What happens is toxins at early age. And when you infect toxins at an early age, the sprouts were nearly touching the muscle. And you inject it again, and there was no effect, because maybe in 2 weeks, again, the sprouts were there in the muscle. That's why very important to really stay distance between session and session. And I call it the lavage one, or the cleaning session, which I leave the patient, oh, it didn't work, maybe because I injected. Many patients come to me, they injected toxins in a friend, and they want to change him, and they want to join my clinic and do toxins with me. And I tell him, when you did the toxin, he told me, oh, 6-7 months ago. And he's lying on me. He did maybe 3 months ago, because he wants to do my toxins. So that's why these patients beware, because sometimes you can inject toxins and it cannot work. That's why I explain to my patients before I inject them, beware, tell me the truth, because there is something in medicine called sprouting. And if you are in sprouting, the toxin you are paying now will not give you any result. Oh, no, yeah, I injected 3 months ago. Okay, you have to wait now, my friend, and I can inject you every 3 months. And that's how we deal.
Okay, Dr. Nabil, there's one more question here. Can you explain the reconstitution for mesobotox?
Yes. So in mesobotox, what we do is we take 10 units of toxin, only 10 units, and we mix it with 1 cc of hyaluronic acid. And when we mix the 10 units in 1 cc of hyaluronic acid, and we make micropapules in all the skin, maybe every area would have maybe 0.05 units of toxin, which is nothing. It will create a high relaxation of all the skin, because it will diffuse maybe sometimes to the internal muscles, and also the skin will become a bit more drier in people who have maybe too much glands in their skins, and it's a good indication to create dryness on the skin for people who have oily, and also I've seen some people injecting for people who have acne as a mesotoxin botox. By the way, just they can collapse the oil production, and this is how we do it. I'm not so fan to offer these types of treatments because I have other options in my clinic, from lasers, from other options, which I can really resurface the skin to a better effect and reach my skin to have a unique skin with lasers or with other options of procedures.
Dr. Nabil, there's a question that says that can Botox be used in post-traumatic ectropion cases?
Yes, you can use toxins if there's any contraction in the muscle to relax. But if someone has ectropion, then it needs elevation and surgery. But if there is anything that creating the ectropin to exacerbate by muscle contraction, you can relax it.
Dr. Nabil, how do you diagnose an orbicularis lower orbicularis hypertrophy from fat prolapse?
So it's very easy. Normally the muscle is higher and then below it there is the fat. So when I'm discussing the fillers, this area, I will remember this question and I will let you show the difference between fat and muscle hypertrophy.
Dr. Nabil, I have a query from my side. Hello?
Yes.
You can hear me?
Yes.
So we inject Botox or botulinum toxin, be it Xeomin or whatever it is, into the masseter, and the masseter goes into atrophy. So we have muscle atrophy there. So what do you say about the muscle atrophy which can happen to the frontalis or the corrugators or the processors when we keep on injecting into these areas on a continuous basis? Anything you would say that?
So there is no study that have demonstrated that repetitive toxins of these muscles create atrophy in a way that you can't move or you can do. But yes, we have seen that with time you have less wrinkles. And myself, I find since I inject toxins that I have less wrinkle with time, whatever lasers I do or whatever things I do on my skin. But I've seen that my patients reduce with time the use of toxins because the muscles become a bit more weak. But in a way that they can really continue. I can tell you something. I was with Dr. Guy Masri, and if anyone doesn't know him, I could say that he's maybe the god of eye surgery worldwide. And one day I was with him doing a surgery, and he you resected 90%. You only left a small part around the muscle. How is this? The patient can close his eye. He told me that the sphincter of the eyes is so powerful that it's super powerful. If you resect 90%, the patient can still continue to close his eye. And that thing, it made me feel very safe whenever I do eye surgery. I can resect all the muscle I want because I know up to 90% someone can close his eyes. And also it happens the same with the frontalis muscle. Imagine we do surgeries regarding brow lift or whatever, or craniofacial surgeries or whatever. And sometimes we can cut the muscles. The frontalis has been dissected, we've cut or whatever. The muscle is very powerful. It maintains its tone. Since these muscles are extremely powerful muscles, then again, you can really not feel that they will lose power. Again, many people cut the corrugator muscles. They cut them and they have seen that the muscle is so powerful to reconnect again and move again. And that's why they cut it and they put a spacer in between by fat or putting a space just not to leave them to connect, because these muscles are very powerful to really give these actions in the face.
Dr. Nabil, there's two questions. One is, how can you treat necklines, and how do you use Botox for MPDS?
How can I use Botox for?
MPDS, myofunctional dysfunction syndrome. MPDS?
Yes. So, in fact, you can use for the neck. I use Botox for prevention. I don't use Botox to reduce line wrinkles. It can improve a bit, but technically we use fillers more for the neck to improve the line wrinkles, or some lasers or whatever. So for the syndrome, what we can do is, depends on the case. Normally, neurology doctors work with this, but depends on the case. You have to know where to inject and how to inject and the quantity to inject. These patients, and normally I refer them because I only based on doing cosmetic cases. And there is something which I've learned. And anyone who have joined me here and saw me, I say myself, I'm like a Range Rover. I do a lot of types of surgeries. I can go hill, go sea, go whatever. So I do a lot of surgeries, and I consider myself that I do all the terrains I can do. Some people are like only doing rhino, people only do eyes, but I do everything. And also in cosmetic, I can do everything. But there is one trick that you have to know. Always try not to do everything. Leave something for someone who does it very well. And you refer them to them, and they can refer you more cases, which they say, okay, he does this, so let's refer him to him. So technically, try not to do everything, because leave some spaces for others who are better than you, because sometimes you can get back referral from them.
Yeah.
What more?
Dr. Nabil, there's one question. They say for migraine, how do you inject Botox? Where do you inject, and how much do you inject?
For where?
For
which
migraine.
area?
For migraine.
So for migraine, it's very important to know if it's really a migraine or not a migraine. Many people knock my door, I have a migraine. Are you diagnosed as a migraine? No, then go get diagnosed. Because sometimes maybe he has a brain tumor that's creating any complications. So first get the diagnosis, and then I can help. You have a diagnosis of migraine by a neurologist who have diagnosed you, yes, I can treat you. So pains in the face could be 3. Tensional, which you can treat with toxins, migraine, which you can treat with toxins, and jaw pain problems, you can treat with toxins. So jaw pain problems, I just inject in the masseter and in the pterygoides medialis from inside the mouth. And sometimes I have to inject in the pterygoides lateralis, and I inject it from here, sometimes. And mainly, this is how I deal with jaw pain. For tensional pain, technically the tensional pain are pains here. So I inject the cosmetic part as if I'm injecting cosmetic, and the temples. Migraine are more excessive. Sometimes they go here, they have pain in the shoulders, they have pain in the neck, in the occipital. So I really target where is this pain. Technically, I inject the cosmetic part and around the head. And there is still the 4th problem that we can have is myofascial syndrome, which is sometimes not related to masseter problems, occlusal problems, bone problems, masseter occlusion, many problems. And some people have fibromyalgia, which they have a lot of pain everywhere. So technically, these patients I try to deal with as migraine, targeting all the muscles that could be feeling he has pain for them. And I reassess at 2 weeks, and if he need more, I add more. I should tell you something. These patients, they spend a lot of money for migraine. And I can tell you that I have like 9 patients who are my typical migraine patients. Every 6 months, they come, and they can leave a lot of $1,000 for this treatment. So you have to really take them very well. Try to make a special price for them, because they are doing something for a medical use, and they will be using it forever. Imagine if you really can do them a favor, whatever you're gaining less, then you will have them forever. Because if not, they will search for other people doing it at a less price, and they will you lose them. Because migraine, it's not difficult. It's easy. You inject everywhere, and everyone is dealing, and they are repetitive treatments forever.
Dr. Nabil, what is your protocol regarding scar revision and the role of toxins?
So for scar revisions, in fact, when I do surgery, because you have seen me, I do surgeries and I inject toxins after the surgery in all the scar. And you tell me why you inject toxin in the scar. And if I'm taking nanofat, I inject nanofat in the scar, because they've seen that injecting toxins or nanofat in a scar improve the scarring. So if you are a surgeon and you want to feel like you are a high-end surgeon, and patients come to you, you have to give something different. And what people see in your surgery is the result, but what others see in the surgery is the scar. So you have to deal for the patient to give him a result, and for others to get criticized, which is your scar. So for the scars, I become so much crazy. I really want all my surgeries not to have scars. I try to offer for the patient free treatment sometimes to make my scar to be like 0 or less, because finally it's my trademark. So people want nowadays surgeries without scarring. So try to tell them that you can help him with this, and you have all the possibilities to improve them.
Okay, Dr. Nabil, there's one more question. What is your take regarding toxins for TMJ internal derangement, anterior disc derangement, pitch reduction, and TMJ click?
So for TMJ, you know me that I'm more focused in cosmetic. So technically, I don't receive a lot of TMJ problems. Barely I receive from time to time. So maybe there are some people are more advanced with toxins in TMJ more than me because they are more updated. So I would be giving an answer which is up to my level of knowledge. I can tell you that for TMJ, pain and clicks and whatever, you have to inject in the masseter and the pterigularis medialis. Yes, I know there's a study published in Sevilla in Spain by Jose Montes Carmona, which I read his article, and it's his thesis also regarding this. And he was injecting in all patients who have pain toxin in the pterygoides medialis, 15 units, 25 units in the masseter, in every masseter, and 25 units in every pterygoides medialis. And he made a study, and he seen that patients improve their pain scores, and they were much more happier.
Is there any role of toxins for hair growth in the scalp?
Up to what I know, there is no effect of hair growth with toxins. And technically, toxins, we can use it for hypersalivation in the glands of the floor of the mouth. We can use toxins for Freddy syndrome. We can use toxins for sweating underarms, for sweating in the hands. For that reason, I use it, and sometimes they come to my clinic and we do these treatments.
Dr. Nabil, there's one question. When you inject Botox for the masseter muscle, sometimes the patient says that they have headache. So do you go ahead and inject also in the temporalis at that time?
So if they have headache from the toxin, you mean, or they have headache from the injection?
Headache after the injection. They say that in the temporal region, they usually have pain. So do you go ahead and also paralyze the temporalis muscle to balance it?
So I never had any patient who told me that he has pain after 2-3 weeks after injecting toxins. And I review all my patients at 2-3 weeks. I can tell you that maybe sometimes they can have pain in the this area, because whenever you inject the masseter, you can create small hematomas inside the muscle, which can translate pain, whatever. Happens with fillers also. Whenever you inject in the temples with needles, people can feel pain for 2 weeks in their jaw and their temples because you're creating a damage in the muscle, and this damage needs to get repaired, and the muscle creates a contraction, and the patient feels this area as a pain. But I didn't refer to someone who had pain because of an injection more than what I've said.
Dr. Nabil, one more question. They're asking that if we are giving combination treatment like Botox, fillers, lasers, so what should be done first, and how much gap should be there between the two different treatments if gap is required?
Okay, so lasers that do not create skin inflammation or peeling, example, I have Aerolase Neo or special NDX or special machines or machines that are radio frequency or whatever, you can do the treatment and then you do the toxin at the same session. But lasers that create peeling, inflammation, any aggressive reaction on the skin, you should maintain them for 2 weeks. Why? Because if you inject toxins and inflammation happens, the toxin can diffuse and can create a complication that we don't want.
One more question, Dr. Nabil, is after the patient takes Botox, what precautions should they take? Can they go gymming? Can they do sauna baths or other stuffs? What precautions will you tell your patients after taking toxins?
I tell them 2 things. Do not massage, which is very important, because if you massage, you can make the and do not do sports for 48 hours. So I tell them no sports and do not massage this. So, and technically patients abide by this. And one of my patients who I had eyelid ptosis was his father death. And his father died the same day she did toxins, and she was crying all the night. And she was crying, and massaging, and the toxin has diffused. And I remember this patient, which I injected only 1 point, which was this point, which not the other point that can create diffusion. But massaging the toxin can create eyelid ptosis. Beware. And that's I learned from this patient, which I had an eyelid ptosis. I had 4 cases which was done because I did it, and 1 case is because she did it by massaging. These 4 cases, 1 patient was twice, the same patient, thin patient with very thin. That's why I learned from this. And the other 2 patients, by chance, it happened. Maybe they massaged, maybe I made error, maybe diffusion, maybe whatever.
Dr. Nabil, coming to ptosis, you said that iopidine is to be given as eye drops for ptosis. So the question is that for how many days does it have to be given and at what interval?
So the iopidine should be given for till the eyelid ptosis is recovered. Technically, 1 month, 2 months, as you see more recovery and people can stop it. We only put it in the eye, which is affected, and we put 2-3 drops in every 8 hours. Okay. So something I should tell you regarding this, that whenever if you have an eyelid ptosis in your area, let's say Dr. Arun Panda in Mumbai, he should have another doctor in Mumbai who has really trust in him. And I would recommend to refer the patient for another evaluation with another doctor to explain him the same thing. Because I've seen that if the patient is explained by a good friend that can really support you, the patient becomes calm. Because the patient starts reading online, start making stories from this, he thinks it's forever, and he becomes so much nervous. That's why really have good friends around you who can really support the same idea. And because I've seen patients, one of my patients child an eyelid ptosis, she knows me that I have reputation here in Lebanon and I have international reputation. And with this, it didn't save me. She went to another doctor and finally the other doctor told, oh, he injected wrong the toxin for you. And then she came to me, she told me that the doctor told her that I injected wrong this toxin. And the bad thing of this doctor that he sent it by a voice message to her, which is saved. So beware whenever you talk with your patients on WhatsApp or anything else, these things are saved. If someone want to really target you later, you're targeted. That's why talk with the patient, explain with the patient. Whatever you talk about, please have not talk about that about colleagues. It happens to everyone. If it happens, then you have to try to explain. I mean, infection of a surgery, anyone can happen. Doesn't mean the surgeon wasn't doing a good sepsis. It can happen with good sepsis too. Or the patient didn't do a good cleaning. So beware not to talk bad about others, because I always say, God will get it back to you if you do this. So try to be respectful with everyone.
Dr. Nabil, there's a question. Can you explain how to treat gummy smile with Botox?
So gummy smile with Botox is very fundamental. I go 0.5 millimeters far from the nose, 0.5 millimeters, half centimeter, and I go very deep and I leave 2 units in every side. By putting only 2 units here and 2 units here is sufficient to correct gummy smiles. Please do not use gummy smiles injection here. It creates bad smiling. Please do not put more than 2 units. Why? Because 2 units is sufficient to use a lot of gummy smiles improvement. But if at 2 weeks the patient is not too much satisfied and he wants more for whatever reasons, then you can reduce more. What people does not know that every woman should have 2 millimeter plus gummy smile. And this is natural and normal and nice. But some people do not know this, and they come to my clinic, see, doctor, I have a gummy smile. The maximum have 2 millimeters. And they think that this is wrong. First, I explain science to my patients. When they know science, then they know what we want to proceed. And the same thing had happened in a patient who have 4 millimeters gummy smile. If I leave her in 2 millimeter gummy smile, she's very nice. Sometimes over-injecting the gummy smiles create fake smiles, and people will not do it anymore.
Dr. Nabil, this question is dropping again and again. If the Botoxin treatment goes wrong, any reversal you suggest, or you just wait?
So the only option you have is wait. So if it's in the eye, you can use ipracoline. If it's in other part of the face with a paralysis, you have to tell the patient to wait. I tell the patient to create movements. Just explain him like a car. I tell him, see, you have a car, we overfilled the tank, and for any reason, and the only option, try to press the accelerator as much as you want. The gasoline will go quickly. So the same thing do with toxins. I explain this. This is not true, but we try to tell the patients in a way just to let them feel that to do some sports.
Dr. Nabil, there is a query here. How are your results of botulinum toxin in facial dyskinesia?
Yes. So in facial dyskinesia, this is a very tricky question because you can have hyperkinetic and all these types of dyskinesias in the face. And these normally are better treated with neurologists. So technically, I will tell you something. Try to deal things which you think you can deal them, because these cases normally are not easy cases. Whatever you want to charge for them, and technically they can get you headaches. So try to refer them to neurologists who have more experience in these problems, and they can really treat them. Also for facial paralysis, sometimes I send them to neurologists, and sometimes I treat them because maybe they are my clients and they really want me, and whatever, I can go and deal them. And for facial paralysis, it's very easy. You can paralyze all the active muscles, nerves, muscle innervations in the non-affected side, except one, the zygomatic majorities and minoris. You should never ever inject them. You can paralyze this, you can paralyze the DLI, you can paralyze the DAO, you can paralyze the frontalis, you can every muscle you can paralyze except the zygomatic major and minor. Because if not, the patient could feel like this. You should leave a little of tension and leaving this. It's very important in these patients to also paralyze the risorius muscle in the anterior part of the masseter, which we prevent it when we inject masseter, but here we use it to paralyze the risorius muscle. And it's very good because it really relaxes the area. Also, I paralyze all the lower part of the muscle, because the DAO and the DLI, because I need the patient to have a very symmetric smile.
We'll take one last query here. Are there any vascular complications related to botulinum toxin if you inject it into the vessel? That is what has been asked.
No, there is no vascular complications, nor happen to be anyone described anything regarding toxin.
I think we should go ahead with our next topic.
Yes. So let me go for the next topic, which is my favorite topic, fillers. I could say that fillers is one of my main core business. And let me share the screen. Okay. Great. So you see now the screen?
No, you need to open the presentation first. Yeah, now we can see.
Okay. So let me start with fillers. So fillers is one of my main. I've been in Lebanon for 3 years and a half. And
yeah.
Yes. And in Spain before this. And I can tell you from when I came back to Lebanon, so I decided to count every syringe I did. I injected 3,000 syringes in 3 years, which it can be equivalent to 12.5 syringes a day. So fillers. Today, area. You don't imagine the areas we have. What filler I use? How do I inject the filler? The danger zone in this area and the trick zone for this area. Okay. So by this, we'll give a good explanation of every area we can deal with fillers. First, I use cannulas. I don't use needles. I use needles only in the green parts. You see the green in the picture? Whereas there is green, I use needles. And in fact, it's for injecting very superficial fillers in a technique called the blanching technique. The rest is injected with cannula. And why I inject with cannula? I inject with cannula because it's much safer and it's better. And I will demonstrate it by articles. And I inject subcutaneously. Always subcutaneous. Not in the muscle, not in the whatever, it's subcutaneous. And always threading technique. Always threading, safer. So why you should use cannulas? If you are still using needles, you have to ask yourself if you want to stay in the past. If you are still injecting with needles, you have several complications to deal with, and I will explain which. First, cannulas are more precise, and it's published, 2017. And needles injection distribute more superficially. Whenever you inject the needle, the filler goes up to the skin. But whenever you inject with a cannula, it diffuses only in the area you have injected. And it's very important, read the article. The second article published in 2019 that the cannula, which is safe, is 25 gauge and 22 gauge. 27 gauge cannulas are risky as 27 gauge needles. So that reason, I only use 25 gauge cannulas for the face. Okay, doing this and explaining that if you inject with needle, you make the material to go more superficially, and if you inject with cannula, you maintain it in the same. I can't understand people who inject the tear trough with needles, because whenever you inject the tear trough with needles, some of the fillers will become more superficial, and you can have more bruises, more tyndall effect, more inflammation, more filler going to more superficial, and it's published. So again, the penetration of a needle in the vessel and leaving the filler in the vessel can create complications. So let's consider the face as a unit, and let's divide the face in 2 units. The upper unit, and we'll talk about all areas, and the lower unit, we'll talk about all areas. So let's go for the upper unit. For the upper unit and the lower unit here, we have several danger areas. These danger areas that we see in the face are related to vessels and related, in fact, to the facial artery more. And as we know, we are all surgeons here, the majority of us, and know very well about the face since we're maxillofacial surgeons. And we know that we have the temporal arteries, the facial artery, the angular artery, and all the other arteries that are related to the lips, to the nose, or the infraorbital bundle. So great, knowing this, we have 18 areas in the upper part of the face that we can really treat with fillers and toxins to improve them. And we will start area by area, discussing point by point to talk about every area. So before this, we know that the upper part of the face is a risk part. So it's very easy to put fillers in the cheek, in the jaw, in the marionette, but it's much more harder to inject filler around the eyes, and it needs more experience. So for everyone who I'm explaining today this lecture, maybe I have reached to a certain level that I can inject every area in the face and I can know where's my limits. But if you are a starter, please avoid to start injecting around the eyes and inject in easier areas, make money there, and we get experience there. And after this, you jump to difficult areas. So remember something, that around the eyes, the risk areas are around the nose, as you see with the angular artery and the nose. You have the temples. The rest of the areas, we can say that they are safe in the subcutaneous level. I'm talking about subcutaneous level. As deep and risky is the supraorbital and supratrochlear, but they are very deep. They are not superficial. So if you're injecting with cannula and superficial, the risk areas are the temples and the angular artery. So let's start the first treatment. So we will be treating the eyebrow hanging. And for the eyebrow hanging, if some patient wants to elevate their eyebrows, so what I do is inject toxins, as you see, 4 to 2 units on the on the same side. On both sides I inject, but I'm putting so you can see how fillers and how toxin we can deal. And I can inject fillers. I open with a small cannula here, and I leave the filler here. I used, as I told you, the company Mertz. So you will see all the fillers I'm using is Mertz, but you can really translocate the fillers to other brands, depends on the brands you use. So every brand has the same thing as any brand, that they have fillers that volumize too much, fillers that volumize half midway with the high G prime, fillers that are soft. So depends the brand, you can have soft filler, mid fillers, or big volume fillers. So in the eyebrow, I use Belotero Intense. It's very unique, this filler, because it has a higher E prime, which will really create, sorry, a higher FN prime, which will really create a more resistance and will elevate the eyebrow. I use 0.4 cc in this area. So as you see, this patient, eyebrows are more fuller and they feel much more elevated, and I use 0.3 cc in the lateral brow per side. As you see, this is another patient, which she also removing a bit of their hair. You could see that the eyebrow is higher. With putting some fillers under it, it feels that the skin is much tighter in the upper part. I use 0.5 cc in every side, and also I put some toxins in the lateral side. So the second area to know is that this area here, there is no vessels when injecting the eyebrow. So it's technically safe, and there's nothing that can complicate your injection site. So if we go to the more lateral side, we have the temporal artery, and the temporal artery is superficial. There is a very thin fascia covering it, subcutaneous, and some of the skin, but it's barely superficial. And you barely take care whenever you inject here. I prefer to use cannulas and not needles because of one reason, because I don't want the patient to feel pain whenever for 2 weeks after injecting this area with needles. So this area, the transition from the temple till the forehead and the eyebrow, as I said before, I put in the eyebrow. Here I will be putting in the transition 0.5 cc of bilotero volume, and this 0.5 cc of bilotero volume will give a very nice transition between the forehead and the temple. So you see the transition, how nice it is. I used in the transition 0.5 cc of bilotero volume. So one thing that we're doing in this lecture, that we are stepping away case by case, and if you want to answer questions, please answer them now and ask them now, and I can really for every area discuss things. So I open the questions for the eyebrow elevation and for the transition from the temple till the forehead. So anyone has any question about this?
Dr. Nabil, how do you make the transition in the temple region?
So for the transition of the temple region, I open a small hole here, and I go with a cannula, and I leave the filler in this side, and I massage very well. So it will create a nice transition in the defect that I have between the forehead and the temple. You see the temple area is filled and the forehead is filled, but the transition area is weak. So I need to fill this transition area.
Dr. Nabil, how long does these fillers stay, and after how long should you repeat it?
So all fillers depends. This question depends a lot on the patient, on the technically between 6 months to 1 year fillers could last.
Dr. Nabil, when you're using the cannula in the temple region, how deep do you go at the level of the bone, or do you stay within the muscle?
So with cannula, everything I do, everything I inject subcutaneously. So everything is injected subcutaneously in all parts of the face. 99.9% of my injections are subcutaneously.
And how do you determine from which direction are you going to inject in the temple region? Is it superior or lateral or posterior? How do you determine that?
You should feel comfortable with the cannula, so you decide from where you want to go. It's as if taking wisdom teeth. You can go from the right, you can go from the left. If you feel from the right is better, then you go from the right.
And how much of LA do you inject? Do you inject just at the point of entry, or do you inject in the whole area?
I inject the filler. I make an entry far, a bit far, just because I don't want the filler to reach there. So to go outside from the entry point, I mean. So I go far and I inject the filler, and by this I could really, let me see if I can explain this. I'm trying to go backwards. Okay, so normally, no. Let me go backwards. Sorry for this. So technically, whenever you inject, you decide here, I decide here exactly that I'm going, and I go with the, because I don't want the filler, if I press or I massage, to let the filler, if I make the opening very near the area, then when I massage, the filler can go up from here. So I need them to stay in this area. So I leave this, I press this area, and I massage very well the area.
Dr. Nabil, do you use LA at the entry point of the cannula?
You mean local anesthesia? Yeah, yes. In some patients I use, and in other patients I don't use. So it depends the patient's feeling of pain or not.
In relation to the supraorbital rim, when you for the eyebrow elevation, how do you plan and how do you exactly inject the filler?
So in fact, whenever I inject the eyebrow, I'm finishing here. So there is no problem with the supraorbital and supratrochlear because I'm putting only filler in the lateral part of the eyebrow. So there is no problem related to these arteries and nerves, which I'll be discussing, correcting hollow eyes later.
And how much do you inject in the eyebrows?
0.4 cc as maximum.
Dr. Nabil, do you think, in your opinion, it is better to also inject the supraorbital rim and the temples together to get a nice brow lift?
No, depends if the patient has hollowness in the temples, you need to fill to create a much nicer. But I don't think that the temple can create any improvement in the highness. And this is very easy to explain. If you do surgery of the temples and you tension the skin backwards, the eyebrow does not elevate. What does the eyebrow elevate is an eyebrow from upsides.
So do you inject the forehead a hollowness as well to give the eyebrow a lift? Do you believe in that?
If the patient has, I would recommend yes.
Dr. Nabil, there are some people who advertise that they do Botox or fillers for eyebrow lift. So is it really very useful and the results are really good, or surgery is the better option?
So surgery is the better option. So with toxins, you cannot do brow elevation. It's just a big lie and a good lie. So what you can do is create to relax the muscles, to paralyze the muscle. So when you smile, it gives the eyebrow to be a bit more higher effectively, but it does not create at repose any brow lift elevation. Fillers at repose can give a bit of little inflammation under the eyebrow, which can translate in a feeling that the eyebrow are a bit elevated. The elevation is minimal, which really, I think some people feel the difference because they value some self and they have maybe a deficiency of volume in the eyebrow. And when we put volume to the eyebrow, it feels much plump and much elevated. But technically, in my eyes, I can't say that this is really a brow elevation.
So technically, we can use a combination of fillers and Botox to bring about a slight elevation of the eyebrows.
Yes, we can sell it in this way. It's an improvement and giving a little elevation for the eyebrow.
Is there any difference between injecting between males and females for the eyebrows?
So technically, men doing eyebrow lift for fillers, it's not the indication. These people come and they need surgery because they have very low eyebrows. And I never had any man who knocked my door to do fillers for his eyebrow more than a surgery and needed a surgery. So technically, they should be the same. But technically, men who knock your door to do eyebrow lift or eyebrow elevation are mainly men that they have a lot of ptosis.
And when you inject, when you are using the cannula to inject the fillers, is there any particular technique that you use, like fanning and threading motion, or you just inject in the bulk?
I always do threading and bulk threading, I could say. I mean, it's not bulk because you leave like 0.1, 0.1, 0.1, and you massage them, and by a threading movement.
The skin in this region is very thin. Suppose if your filler is injected superficially, how do you get rid of it?
So if you inject it superficially, you can use days to eliminate it. But I can tell you something, that the Belotero range of MERTs integrates so high. And if you want, I can show you studies regarding integration of this filler. I can finish with this. And that's why you can inject it more superficially and you don't have any problem, nor Tyndall effect. It's the only filler in the market that does not have Tyndall effect when injected superficially.
In case of Belotero, what would you recommend for the the brow part, and which Belotero filler would you recommend for the temple part?
For the temple part, I use Belotero volume. You could see in all images, I'm putting the product I'm using and I'm putting the quantity I'm using. You see in the slide? So in the temple, I use Belotero volume and I use the transition 0.5. And in the temple, I use also bilateral volume, which we'll be seeing it now after this. In the temple, I use between 1 cc to 2 cc's, and I do the same technique of fanning, as you could see, and I go from the back, and I use bilateral volume. For the eyebrow, I use bilateral intense.
Dr. Nabil, since most of us are max fax here, so a little deviation from the point of discussion of fillers here. What's your preferred approach to do a brow lift? What do you normally prefer? What would be your preferred approach? Surgical.
For men, I prefer the direct incision over the eyebrow. It's the most powerful one to give them really good results. For women, I prefer to do the temple incision, temporal incision.
Wow.
Technically, eyebrow lift surgeries, you gain maximum 0.5 millimeters. They prolapse with time. So the only one who does not prolapse and it has a potent effect is the direct one. But technically, you have to leave a scar over the eyebrow, which mainly in my country, people have tattoos, people have coverage of this area, so they don't care about the incision.
Great, thank you.
So maybe we can continue the temple depression area. So in the temple, I inject bilateral volume. I use 1 to 2 cc's. I inject with cannula and superficially in this way. And as you could see this patient, you could see the deflation of the temples and how we fill them to create them more. We use 0.5 cc per side, sorry, 1 cc per side in the temple, 1 cc. The temples eat too much. You minimum need between 1 cc to 2 cc's. Barely sometimes, if someone has very little, you would use 0.5. I will always recommend to use 1 cc per temple as minimum. Technically, it depends the indication, but mainly I use 1 cc. And as you could see, by filling the temple area, the patient has a better effect and much more filled. Remember in the temple area that we have the superficial temporal artery, which is exactly under the skin, and sometimes it's translucent under the skin and you can see it. Try to advance with the cannula slightly. Try not to push hard in the soft tissue. It should advance. Technically, with a 25 gauge, it will not penetrate, except if you hit it very hard and you go directly to it. If you are passing by it, it will pass and you will leave the filler very well injected in the subcutaneous area. Okay, so as you could see something, this is because I do also lab anatomy surgery. And as you could see, normally the filler is injected in the subcutaneous part. Beware if you inject in between the two fascias, the filler can go up, can go down. And again, as you could see, we have layers here. I always inject the filler in the subcutaneous for integration. I don't want the filler to stay here because the filler will not integrate in between the fascias and this can slide from up to down. So you have two options to inject the filler, or you inject under the muscle, or you inject in the subcutaneous plane. If you inject under the muscle, you need too much syringes. You need a lot of syringes. So that's why I prefer to inject more superficially. With a little quantity, you can give better results. So this is not to discuss here. It's about facial danger zones, arteries, and nerves. But technically, if you don't know, we have a transition area of the nerve from deep to superficial, and is this area which I can discuss in another slides or another conference. If anyone would like to know all my lectures, the International Academy of Aesthetics, he can text me by Instagram or by email. I can send him link to all my lectures in the International Academy of Aesthetics. Very detailed lecture, anatomical lectures for every treatment, for chin, for cheek, for whatever you want. I've made a huge impact of my time to build up nice presentations. So as you could see, this area, the transition area, it's very important in this area to inject all the fillers superficially, okay? So for temples, do we have any question?
I think we can carry on.
Okay. So for the lateral part of the eye, which is, it's not the temple, is the anterior part of the temple, nor the tear valley, nor the tear trough, is the lateral orbital depression. Some people come with lateral orbital depression. So I use bilateral balance superficially, or I use, subcutaneously, or I use bilateral intense if the depression is higher. I use mainly 0.5 cc. And as you could see, this patient, she has tear valley, tear trough, and lateral orbital depression. And technically, we can go with a cannula, as you could see. You can penetrate inside. You should feel that you're penetrating the muscle. And I advance and advance. You should feel that penetration of the muscle is very important. Now I penetrated the muscle and I'm under the muscle. And as you could see, if I'm under the muscle, the cannula cannot appear superficial. And you start leaving the filler. So the same thing, you can treat this lateral orbital depression by penetrating, and you need to really penetrate the muscle. You should feel that you are under the muscle. And when you're under the muscle, you feel that the cannula is there, and you leave the filler to correct. And then you go more up and you start correcting more the upper part of this. It's very important to leave the filler under the muscle in this side, under the orbicularis oris muscle, to give a better improvement. So the same thing for the lower part. If you want, you see, you fill this area, and then you want to fill the lower part. You can still building the same issue. You have to go under the muscle. You feel that you are under the muscle. You try to elevate the cannula to feel if you can see the cannula. I can't see the cannula. That means it's under the muscle, and I start leaving the filler to go there. So by this, you could see the depression she has and how we corrected everything around the eye to give a very nice transition, lateral transition between the temples and the eyes. This is another patient which she did upper and lower blepharoplasty with another surgeon. She had a depression, huge depression here. You see the depression, which gave a very awkward result of her eyes. And see, by filling these depressions, the eyes appear much more healthier and appears to be much filled this area. Okay, you see the depression in this lateral side of the orbit, how it's very, very seen. And when you fill it, it gives a very nice contour and a very nice transition. Anyone has any question for lateral orbital depression?
No
Dr.
queries.
Nabil, when you go when you go towards the tear valley part, when you're injecting the filler, how do you gauge
I would
the
recommend
thickness?
everyone who's having questions to really text them before we reach to stop. So the moderators can really read the question and directly pop it, and that with this we can advance easy to another area.
Dr. Nabil, how do you inject? How deep do you go when you're injecting into the tear valley area?
Okay, so maybe we can proceed for another area. If not, we can answer. So something is very important for this area too. Remember something, that there is an artery exactly over the zygomatic arc. And this artery, if you cut this, it can pop up. And beware people who inject with needles in this area and they go deep. They can really inject in the artery and in the vein and can really create a complication. So that's why I use cannulas and I use subcutaneously, and I don't go with needles deep. So for the tear valley, it's very fundamental, the tear valley, which is the continuous of the tear trough. To use filler under the muscle, always under the muscle, I use Belotero Balance, and sometimes over the muscle, I use Belotero Soft. And the Belotero Soft will give hydration to the area and improve to give a better result. And the Belotero Balance will correct the depressions that we have in the tear trough. And as you can see, this patient, I did for her several fillers in many areas, but we're discussing about tear valley and continuity of the lateral part of the eye. Feel how this is very thin face, non-healthy, to a healthier transitioned areas, as you could see. So this is another area treated for the tear valley. You could see the filling in a way. This patient has hypertrophic muscle. You see the hypertrophy of the muscle because the fats normally are more here down, and this is muscle hypertrophy. And this is another patient which we filled the tear valley to, and the transition lateral orbital depression correction, and tear valley correction. Sometimes these two areas are connected and you need to overcorrect them. And in this case, it was 0.5 cc on this side and 0.3 on the other side. This is another patient which we corrected the tear valley. You could see we used 0.2 cc balance on both sides of the tear valley. So for the tear trough, it's very important for the tear trough to really inject also under the muscle. Never inject fillers over the muscle. Please never inject in the tear trough with needles, because when you inject with needle, the filler will pop up and you will leave so much superficially, and it can create lumps and effects. So you usually start from below here, go with a cannula and leave the filler. As I say, try not to inject filler in the upper part, because it can really, it's very hard and it's painful. Try to be in the tear trough exactly. You could see the correction of this patient. We use 0.5 cc in the left and 0.5 cc on the right. You could see this patient again, how we improved his tear trough and tear valley. For sure, he needs surgery, but he didn't want to do surgery. We also did some temples on both sides. We corrected also the cheeks. You see the effect of cathetic patient who has a disease, and this patient, he feels healthy, filled, and nice volumization effect. We use in her tear valley 0.5 cc's, and in her tear trough we use 0.5 cc's. In fact, 1 cc in all his eye, as you could see. So for the tear trough and tear valley, remember something, Rahul, this is the muscle and this is the fat. So normally the tear trough is between the fat and the bone, the hollowness. So this is where exactly we need to leave the filler. For this hypertrophy of the muscle, I can really inject toxin to relax it. And I will show you this in one of the slides of a patient. And technically, whenever you leave fillers and in the eyes, should really leave the filler under the muscle. And in fact, if you want to be very specific, you can really inject also the filler under the septal fat, the fascia of the septum. So I usually recommend not to inject the filler under the muscle, exactly under the muscle. If you do surgery of the eye, you know that you can go more deep and you can inject in the septums, under the septum of the fat. And this is better because the filler will really have a very nice contraction, because the septum will contract the filler in a way that it will fill up the area, and it's much safer, and it has a better result than injecting over the septum under the muscle. When we go to meetings, we say under the muscle, but technically it's not correct 100%. All well-known injectors inject under the septum of the fat. And that's, if you don't know this, I would recommend to go to see a surgery, lower eyelid surgery, and you can really understand exactly where you have to leave the filler. If someone joins me here in Lebanon for a fellowship or for something else, I can really explain him and let him see exactly where we inject. So again, for tear trough, there is a lot of problems that some can help and can correct with fillers, but others cannot correct with fillers. That's very important and very fundamental to discuss it with patients. So one of the things is recommended for patients is, if it's too much excessive fat and excess skin, I would recommend to do surgery. If the patient has less and is young, he wants to get an improvement, or he is old but he doesn't want to proceed with any type of surgery, then you can improve them with fillers. So for tear trough, does anyone has any question? And tear valley, tear trough, tear valley questions?
Dr. Nabil, if a person is going for a re-injection after a filler injection, so do we need to dissolve the filler, or we just inject it within a year time?
So, okay, no problem. Maybe you can leave the questions for the final, and you can think about questions that you could have in mind. So let's proceed for the next area. So the next area is the, in fact, an area which is very difficult, the SOOF. Some people come to my clinic and they have SOOF. This SOOF is hanging, creating a depression under it. And sometimes the only option to correct this is doing surgery. But patients who have minimal effect, I do inject under the ligament below volume to pop up this ligament and tension it. And then I use the cannula and I dissect the ligament. I try to perforate the ligament to make the ligament to just the skin to not create a tensioning and relax a bit. And I put in between the ligament and the muscle some below balance. I use 0.5 cc's of below volume, and maybe I could use 0.3 to 0.5 cc of below balance to correct this. As you see, this patient, she has a depression. This is very hard to see it by pictures. It's much more visible by real and reality. And sometimes these patients can tell you, okay, in pictures I don't see it, but when I really see myself in a mirror or people see me, I see that there is a depression here. You could see how we filled it, we improve it. See the OG curve. You see the OG curve from the lateral view here, how it's doing, and see how it's nice transitioned and a circular effect we can have from the other side. This is another patient having it. She still has a bit of pigmentation, which may require to peel, but the patient doesn't have any more this depression and this sooth effect hanging on the cheek. So as you know, for tear trough, tear valley, sometimes we have to do also, and for this area, sandwich technique, which is putting fillers under the septum and over the muscle and under the skin, so we can make a sandwich technique for a more improvement result. And technically, beware whenever you inject with needles, there is the artery coming from here. You can perforate it whenever you're correcting something in the corner here. Some doctors would recommend not to go with the cannula up to this level, but I can tell you that I reach with the cannula to any level. I try always to be safe. First, I dissect, and whenever I dissect, I can see if there's a creation of hematoma or not. If an hematoma happens, means that I perforated a vessel, then I should not inject. If I don't see hematoma or any reaction, means I'm safe, I didn't went in any vessel, then I can really inject any filler. Remember, the artery, it's coming here. So to take it into consideration that when you're going with a cannula, technically this artery is very lateral. I do a lot of surgeries and medial. It's very rare to see big arteries. Going with a cannula under the septum is totally safe, reaching up here for the corner of the eye. So again, for the lines around the eyes, here, as you could see, these lines could create wrinkling, and sometimes this wrinkling cannot improve with botulinum toxin. Then we need to use fillers, and we use Belotero balance to inject very superficially in a blanching technique. And I do also toxins. By putting toxins and fillers will create to improve a lot these wrinkles. It's very important to say that I'm injecting with blanching technique, which means superficially, extreme superficially. You can do blanching with any product in the market except with Belotero. So take care into consideration this, because the only product in the that has been published that you can do blanching and you don't have Tyndall effect. So again, this is a patient. As you could see, we did some toxins and some blanching, 0.2 cc per side, and you can see the improvement of the wrinkles around the eyes. Also, for wrinkles in the forehead, you can do blanching for people who have, and you can associate with toxins to improve them. And you can do blanching, and with blanching, you can really create improvement of wrinkles. This is me with some toxins. You can really reach sometimes, and if there is any wrinkle you can really want to address, you can really do fillers. Some people have a frontal depression. It's not wrinkle, there is a depression here. They had frontal bossing and they want to camouflage the frontal bossing. So I use Belotero volume if depressions. Little depressions, much more superficial, I can use Belotero balance. I go with the cannula, I make an entrance here, and I leave the filler in this area. I use around 0.5 cc of Belotero volume for big depressions. This is a patient, as you could see, she has a depression here. You could see how it's the depression is big and how we improved her depression and improved her skin. Other areas around the eyes is the 11 code, which I call the corrugator lines. Sometimes they need filling deeply with Belotero balance, and sometimes I go and inject them more superficially with Belotero soft in a blanching technique. And as you could see, and one of the most important things is whenever you inject this Belotero balance very superficially, you have to take care about the blanching technique that you can only do it with Belotero. And I can associate with Botox, so you can really get a better result for this area. You could see this patient. I injected first 0.6 cc of Belotero balance deep with a cannula. I make an opening here, and I leave 0.6 of Belotero balance deep, And then I use 0.2 cc of Velotero balance in a blanching way, very superficially blanching technique. So I can really let it, I could say, improve it to 95%. And I did some Botox to create relaxation of this area. This is another case, same thing. I use 0.3 deep, 0.2 blanching technique, and toxin in this area to improve it. So for nose wrinkles, also the same technique. We do blanching technique. For this, if you don't know what is blanching technique, you can read an article published about, you put blanching in PubMed and you can read it. I mean, I can talk for fillers for 3-4 days. I'm trying to compact everything to be in 2 hours, 3 hours to finish. So try to, you can understand and have an overview of all areas. I can associate always Botox for improving the wrinkles of this side with this inverted V's. So I can add toxin here. I can relax all these wrinkles here. Sometimes patients come with wrinkling here. I inject Botox this and this. So all the wrinkles around the nose can appear to be less. You could see she may require more retouch. I usually don't put here too much, 1 unit, but this patient needs a retouch of maybe, again, putting 1 unit, 2 units, 2 units, 2 units or more, so she can get a better improvement. For hollow eyes, it's one of my favorite procedures. It's the most difficult procedure in eye and correcting around the eyes, maybe with the tear trough. And this is very, and we charge triple the price of everyone because very little people do this. And whatever people less do things, then you can ask whatever you want. So one of the most important things that you need to go with a cannula under the muscle and under the septum. You see this white? This is the septum, and you have to leave the filler under the septum. Sometimes, if it's very hard, some people have very weak septum, you can release a bit of fillers under the muscle. But I don't recommend, never recommend. I recommend to leave it under the septum. And why? Because if you put under the muscle, the filler can expand downwards, can diffuse downwards, integrates a bit downwards. So I don't want this. So I want really to correct the eye hollowness. And I really, the eye, the fat of the eye, the septum fat of the eye to control the filler and maintain it in this area in the upper part. So this is a patient, you see the hollowness, eye hollow, how we improved her. We used 0.2 cc Velotero balance per side. We made an entrance here and we went under the septum and we left the filler in this area. Technically, I associate always a bit of filler injecting in the upper and the lower part of the eyebrow because mainly they have also depression. This area is very critical. You have to feel really where is the supraorbital, supratrochlear. Normally they are very deep, going from the bone. So if you're injecting subcutaneously, it's safe. But in fact, you're going under the septum. And if you're going under the septum, you have an incidence to perforate if you're going with a needle. That's why I go with a cannula. I try to dissect a bit there, feel if there is any hematoma, no hematoma, I leave the filler. That means that I'm safe. So this is a craniofacial surgery, and you see that the arteries and the nerve comes from this socket. Technically, this is from a book, and it's put in a wrong. You should never inject under the muscle. Please inject under the septum. I've tried to inject under the muscle, and it's only giving complications for sometimes movement, sometimes diffusion to other areas, and I have diluted all doctors who did under the muscle. Please confirm that you are under the septum, and this is the best place you can leave the filler. If you don't know this, where is the septum, visit any surgeon who does a lot of eyelid surgery, as Rahul does. Rahul does a lot of eye surgery. You can visit him. If not, you can visit me, and he can show you, or I can show you exactly where exactly the septum is. So for muscle hypertrophy, this is the question that Rahul asked me previously. We inject, as you could see here, the toxin for patients who have muscle hypertrophy. You see this patient, she doesn't have fat. She has eye hollowness and muscle hypertrophy. See, when I injected the muscles, you could see that the eyes appear to be much open, more relaxed. I will do something with this patient. I will take her eyes, so you could see that the opening of the eyes Maybe here they are not shown because she's not closing, but technically the patient feels that the eyes are more open, and the patients are much happier because they feel that the eyes are more relaxed. So whenever you put toxins for this area. The next area is the intercanthal depression. Very risky area, very hard area to start as a starter. Many patients comes here and they want to improve this area before, after rhinoplasty or whatever. So these patients, they have a hollowness here. They are picky so much that they want to correct it. So I used here 0.1 cc of Velotero balance on the left and 0.1 cc of Velotero balance on the other side for correcting depressions of this area. Remember something, that this area you have to inject it superficially, little quantity, massage very well. Remember that it's a risk area, and here with needles never reach this area. Okay, so as I said, with needles never reach this area. So for cheeks, what I do is I inject Velotero volume, and if it's lateral cheek, I call it the Hollywood cheek. I use 1 cc. If it's in the central cheek, I use 0.5 to 1 cc, depends if he has depression or not. And sometimes some people have depressions more medially, and they need also 0.5 cc's. This is a patient which I did cheeks. You could see cheek elevation, how it improved, how it reversed the square part of the face to make it more triangular. And minimum I use in a cheek 1 cc of any filler. With 0.5 cc, you can't do anything. So that's why I recommend minimum to start with 1 cc for people who want really definition. And when it defines so well, I call it the Hollywood definition. So this is a male patient who wanted anterior cheek improvement and some nasolabial. We improved with Velotero volume, as you could see, 1 cc in the left and 1 cc at the right. This is another patient which he has also depressions in their cheeks. And you could see I used 1 cc in the left and 1 cc on the right, and how we have corrected it. Remember, this area is very fundamental, because this area is very safe inject in the subcutaneous level. But the artery and the vein are extremely deep. This is orthodontic surgery. And if you see an orthodontic surgery, this is the bundle, which is deep. Normally it's deep and it gives a lot of ramifications. So if you inject with a cannula in the subcutaneous plane, is extremely safe. The problem is when you inject with needles and you hit the bone and you hit here, and you can make the filler to go inside this. So normally, and take a picture of this because it's very important how we make the Hollywood cheeks. So, and how we define how should be the cheeks. I'll be making a line from the lateral part of the orbit, not from the internal canthal of the eye, lateral part of the orbit to the lateral part of the mouth. And I will draw 3 lines, a line going from the ala to the lower part of the ear, from the middle part of the nose till the tragus, and from the lateral corner of the ear to the upper part of the initiation of the ear. And in fact, I will draw a line uniting the intersection of these two, which I put red point, and the other intersection here, and I draw a line, yellow line. Sorry. And I put another line here from here to there, and this would be the cheek, which you should inject. I go with a cannula from the posterior part and I start leaving. Okay, so this is very nice trick to always put the cheeks on the correct side, and it's not a visual thing, it's a mathematical design shape. So for the nose, I can talk a lot. If we have time, we can discuss it later stage. And for the nose, in fact, I can go from here and leave the filler. I can go with needles, I can go with cannulas. I use between 0.3 to 0.5 cc's to correct deformities. I prefer to use Velotero Intense. Mainly in 95%, I use Velotero Intense. For little correction, I can go with Velotero Balance, but mainly Velotero Intense is the best for the nose. So these patients who have done wrong rhinoplasties in years ago, they come back and they want to do something that they really want to correct it without surgery. We can fill, we can correct. This is another patient. We have corrected it. And remember something in the nose, there are specific arteries which I can really discuss for 1 hour about nose fillers. If we have time, we'll be sitting for this, if not for another time. And they have seen that the arteries are deep, normally in the deep compartment. And that's why you have to really leave the filler or over the bone or in the subcutaneous plane. Okay, so in the upper part and the lower part, all these areas you should really take care because there's a lot of vascularization. And this is everything for the upper part of the face. So if anyone has any question of the upper part, let me know before we jump for the lower part. Do they have any question?
Dr. Nabil, when you decide to go into the intercanthal region of the eye, that medial eyelid depression, when you plan to do fillers, what is your
Questions?
entry point? Hello, Dr. Nabil?
Does anyone has any question? If not, we can continue.
Yeah, Dr. Nabil, I think Dr. Rahul was trying to ask something. So the one slide that you showed about the intercanthal depression, so what would be your point of entry there?
Sorry, I didn't hear. Now I hear. Sorry.
Yeah, so the point of entry for the intercanthal depression.
So like the point, yes. So the point for the intercanthal depression, sorry, I found that I had my speaker muted, so that's why I didn't hear the previous questions. So we can barely respond them now all. So for the intercanthal, this, let me go there and I can show it exactly. So I can go from up or from here. I prefer more to go from below because it's much easier for the cannula. But sometimes what I do is I twist the cannula inside and I try to reach this area. Going from below, the problem is that sometimes the filler can rush downwards or diffuse downwards. And that's why it's much easier, but the filler can diffuse downwards. And going from up, it's much difficult and more riskier, but it's much maintains the filler in this side more and better.
And Dr. Nabil, for prominent malar bone, how do you plan to inject fillers?
So for prominent bones, if they have too much prominent, then you need to study the area of prominency. Normally, people who have prominent here, maybe they have depressed in the anterior part, then I need to add in the anterior part. Maybe they have too much prominent here, but they have very depressed in the posterior part, then I need to add more in the posterior part.
And would you like to mention about the difference in technique for a male and a female? You have mentioned this as a female. So
yes.
Any difference in the male?
Yes, for the male, we don't inject this Hollywood definition. I go from here in the center and I normally inject in the anterior part of the cheek and in the middle part of the cheek, never in the lateral part, because you will create feminization faces for these males.
Okay.
Any more questions?
Dr.
No.
Nabil, when you talk about under eye fillers, what is the complications of having blindness, especially if the filler gets into the retinal artery?
So I'll be explaining this when we finish about all the complications and how we deal with this. So it will be responded later stage.
Dr. Nabil, can you elaborate on festoon corrections?
So for festoon corrections, as I said before, it's one of the most difficult areas to correct, and you need to evaluate this festoon. If it's too much, the festoon, that you really need to address by surgery. But if it's a little festoon that you can really address, this festoon that seems here inside, what we really need to do is just to inject the bilateral volume over the bone, under the ligament of the festoon, so you can create tension of this festoon, and then you go with the cannula and you dissect. I dissect all the ligaments that are going more superficially to cut them with a cannula and leave some bilateral balance under the festoon. This area is much more difficult. I mean, for anyone who would really like to learn more about fillers, the best way is to jump in a fellowship where they do a lot of cosmetic procedures, and they can have a huge experience. You, Rahul, or you, Dr. Arun, Panda, or anyone of us who is hearing us and has been here, he knows how much we do, and we treat every area. So I think it has gave you a lot of expertise in every area we treat.
And, Dr. Nabil, when you're giving in the upper eyelid, how do you confirm that you're below the septum when you're using the cannula?
So it's very easy, because if you elevate the cannula and you are under the muscle, you can really feel the cannula, the skin and the muscle and the cannula. It's a feeling. But if you are under the septum, you feel that the cannula cannot go up well. The septum contracts it and you can't feel that effect. It's like the feeling of a tent. If you're under the muscle, you can elevate it. Can you feel the tent? You can feel the cannula is under the muscle. You put the finger and you feel the skin and the muscle and the cannula. But if you are on the septum, you can elevate, you can't elevate, you feel that it's deep, exactly, very deep.
And for rhinoplasty, when you do non-surgical filler rhinoplasty, what plane do you prefer to stay?
I go in the subcutaneous plane with cannula. Barely moments I use needles, and exactly I use needles for people who want to correct them. The upper part of the nose, the nasion, they have a depression and they only have a depression in the nasion, then I really go with needle. But they have in the eyes and they need several corrections, I go with cannula.
And in case of the columella, if you want to elevate the columella?
Sorry?
If you want to elevate the columella of the tip with the filler?
So, yes, we can. I have a lecture for nose fillers, which is like 40 minutes. I don't know if we will be having time for it. Yes, we don't. So for columella, I go with the cannula from here. I leave the filler up here. But with the columella, I try to push the cannula downwards and I leave the filler in between the columella. Usually I use Brotero Intense. And please do not leave the filler in between the foot plates, anterior to the foot plates. You have to leave the filler posterior to the foot plates so you can really create elevation. If not, you will create hanging columella.
I think we can move on to the next part.
Yes. So there is a question which only went to my phone. Is it possible to show how to reach SPTA for fillers on eyelids? Which I don't know what's SPTA. So just ask this question in the group and we can help you, the one who texts me a message. So let's continue the lower part of the face. So is it interesting till now?
Yeah. I like your lectures.
Oh yeah, it's beautiful.
Okay. Okay, I told you, Dr. Arun, you're seeing new things. Let's continue. So the next area is the lower part of the face. So we'll be discussing all these areas and how I deal with them and how I treat with them. So in the lower part of the face is safe. I could say that mainly is safe for everyone. Anyone can start in the lower part of the face. Do not start in the upper part. For young surgeons, for starters, for whatever, the only area which I can consider is not safe in the lower part, maybe the nasolabial, but the rest is extremely safe. And as you could see, there is no arteries, mainly subcutaneously, in any area of the face, in the lower part, except in the nasolabial part and in the upper part, the upper lip. So all the other areas in the face you can inject subcutaneously, safe 100% approximately. So this area, as I said, it's safe. So whatever you want to do, you can inject in the subcutaneous. Also, the area between the ear and the buccal fat pad, whereas the parotid gland is safe because all the arteries and veins and whatever are very deep under the parotid. So everything over the parotid is safe. And in the buccal area also, there's extremely safe. There's a lot of fat. There's a lot of stuffs here. So you are always safe. The only problem is in the anterior part. In the anterior part, normally this facial artery is very deep, so it's very safe to go subcutaneously. The only part that becomes more superficially is in the nasolabial part and more in the upper part. So let's go from the back to the anterior. So the parotid area depression, some people comes with a parotid area depression. As I said, it's very safe to inject to correct this depression in the parotid area. You see, we corrected with 1 cc of Brotero volume, and correcting this area, it gives a very nice transition and a feeling of a young filled face. Whatever the artery is here, as I said, the parotid gland is here, so it's safe and it doesn't have any problem. The next area is the jaw angle, the anterior jaw angle. This anterior jaw angle, sometimes people wants to create definition or call the Texas jaw angles. So these patients, they want definition here, they want to get improvement. As you see, we go with the cannula from the back, from here or from the back, and we start leaving the filler. And as you could see, we can really improve this area. We use bilateral volume, and for the paraparotid depression, also we use bilateral volume. For the jawline, we use bilateral volume. And as you see with bilateral volume, you can create definitions and improvement and draw the patient's face. This is another patient. You could see that we did the pre-mixed bilateral radies, and you could see the effect of improvement of the jawline. And this, I'll be discussing my last presentation of today about of fillers. It's for advanced injectors, which is very nice, mixing hyaluronic acid with calcium hydroxyapatite for a pro-lifting effect. Results are impactful. You will see how impactful they are. So other areas as this, which is the you could see the buccal area. This buccal area, some people have depressions. I use bilateral volume again, and I use 0.5 cc's to 1 cc's for people who have depression in the buccal area. You see, by filling this area, it gives from cadaveric or HIV patients effect as a more natural and more healthier effect. You could see the depressions in the buccal fat pad area. You can create much more nice. We used 1 cc of bilateral volume in every area. And for this area, as you could see, like to see the difference between both of them. Again, as you could see, this area, there is an artery here, but there is a lot of fat this area, so it's very safe to inject here. So no fear of this artery that comes here. For the nasolabial area, as you could see, we could use bilateral volume or bilateral intense. I would recommend to go more with bilateral volume. It fills more, and you may require sometimes more than 1 cc of bilateral intense. You can use between 0.5 to 1 cc. I go with the cannula from the lower part and I inject the filler all in this area. This is a patient which we injected filler in the nasolabials. As you could see, we used 1 cc here and 1 cc here in the other side, and we went with the cannula from here and we injected all this. Normally and technically, something I will explain. Before I inject everything, I go with the cannula and I dissect first with the cannula. And I've seen people where we dissect their nasolabial, the incidence of improvement of the nasolabial appears quickly. And this is very fundamental. So I tested on a patient, I didn't put fillers. I took cannula and I dissected the nasolabial. And I took a picture. And after 1 month of dissection of the nasolabial, I told her to come back. And the nasolabial have improved alone without putting fillers. And I've understand something that whenever you dissect, you create hematoma, you can create building of collagen production inside, and this can also improve the result of your cases. So first, in all these areas, I dissect. After dissection, I start leaving the filler. Okay, so as you see, also something which is very important in nasolabial, always do not inject over here because we don't want to fill the cheeks, just be medially. And sometimes I need to treat the upper part of the lip and the medial part more medially to just give a nice transition from nasolabial to lip. In this case, we used 1 cc in every side. This is another patient, as you could see, that we used fillers for her, and we used 0.5 cc of bilateral volume. Maybe it's a bit, we could see overfilled, but she wanted this overfilling and she wanted this effect, but she also was worried about this line that she had here, as you could see, and she wanted to improve. So I injected with blanching technique, 0.1 cc. Important, very important blanching technique. You can't do it with any type of fillers except with bilateral. I'm saying this because I don't want people to jump tomorrow, do blanching technique with other products and have complication. Only you can do blanching technique with bilateral, and it's miracle because it really corrects very good the scars or wrinkles. So remember this area, as I said, it's very, very dangerous. It's very superficial. The artery is very superficial. As you see, there's a little fat covering it, and you could see how much superficials are. I don't know how people inject with needles here because God loves them, but the incidence of penetration in any of these arteries here is high. So I always use cannulas. I make a hole and I dissect first with the cannula, and I dissect because I really want to confirm if there's any hematoma here happening. That means I was in a vein or an artery. And it's very fundamental. You see these arteries here. Normally I leave filler also here in the anterior part because I want to really do a good transition between the upper lip and the nasolabia. As you see how the arteries are superficial, how over the lip, the artery is superficial under the skin. You could see how superficial are the things. Again, as you could see, these patients also sometimes have a lot of different arteries types, type 1, type 2, type 3. And I would recommend that these all types, just have them in mind that they can be different from case to case. And that's why you should always go safe, whatever you know the anatomy. So for the upper part lip depression, some people come have a depression here and it feels like they have old lips and they need filling. So I use 0.3 cc of Belotero Balance. I go from here and I inject inside the lip and in the subcutaneous. Sometimes I associate this with some toxins here to correct the wrinkles that we have here. I explained before 1 unit. And as you see this patient, I've corrected the transition and I've corrected the wrinkles that she has here, how they have improved with blanching technique of wrinkles. This is another patient, which I did some fillers in the nasolabial. I did some fillers. I also did a peeling for her skin. And as you see, the improvement of wrinkling and the improvement of filling the areas is very nice. For nasolabial, I used a mixture of volume radiase. For marionette, I used also volume radiase. For toxins, also, as you could see, and in the cheeks and other areas, we have treated her face. Again, as I said, for this area, beware, there is the artery here. So whenever you go with the cannula, be safe, dissect first and then leave your fillers. Going with cannula of 25 gauge is safe, I can consider, but you have to really take care about this thing. So for the lips, we jump for the lips, and for the lips, you have 2 options, or you volumize the lips or you contour the lips. So for volumization of the lips, I use 0.3 here, 0.3, 0.2, 0.2, because the upper lips usually smaller than the lower, and I need to make them symmetrical technically, or a bit more bigger the lower part. So, and for contouring, for filling, I use Belotero Volume. It's the only filler in the market that could be used in the lips as volume. Other products of other brands you can't use because it has very high diffusion and integration that you can use it. It's very smooth also, and you can leave it in the filler and give very nice natural plumps. And you can contour the lips with a intense. You could see this is volumizing fillers. This is volumizing also, and this is volumizing of a patient. This is contouring and volumizing of a patient, you could see. And again, for the upper part of the lip, you can also contour these ridges here, philtrum ridge. And this is a patient which didn't have any ridge, and she wanted lip fillers and improvement of the ridge. We put fillers in the ridge around 0.2 cc of Belotero Intense. I use Belotero Intense for the ridge, you see, and with 0.2 is sufficient to create a ridge in the lip. Again, beware here, whenever you're going with a needle, there's an arteries here. Beware, just try to be superficial as much as you can and leave the filler. Beware in the nose, whenever you put fillers with needles here, it's very risky, high risky. Just that's why I always say inject the filler posterior to the alar medial foot plates. And why? Because if you inject anteriorly, the arteries is here. When we do rhinoplasty, it always bleed, and it's big. So beware, people who inject here with needles. I mean, I don't know how they can risk this. You have to go with the needle in case you want to inject for any reason. You have to inject here posterior and far. If you are going with a cannula, I go directly to the posterior part and I leave the filler posterior. In the lips, also for people who inject with needles, in the lips, there are problems injecting with needles that the filler can go more superficially because you're penetrating from here. And it was published in 2017 that if you inject with needles, the part of the filler will not maintain in the area you injected. And beware, the artery is posterior in the lower part, and in the upper lip also is posterior. So in both areas is exactly here. but posterior. And in the upper lip, it's exactly here, but posterior. And as you could see, in the upper lip where it goes and the lower lip where it goes, you could see it's posterior. But you can put your finger also, and you can feel where the artery of the labial artery comes. And technically, it becomes from deep to superficial, exactly in the central part, the lateral part in the center. So this area, beware whenever you do contouring. If you do contouring here, you will not create hematomas. But whenever you reach here and you do contouring, you can create hematoma because you can perforate this artery that comes superficial. Something that I've told before, that 80% is posterior and the artery is posterior. Yes, this is true. And maybe you are oral surgeons and you do cancer surgery and you can cut the lips and you can find it posteriorly in 80%. But some other people have it intramuscle and other people have it supramuscle. And it's very important to understand this and know this, that there are some varieties. And also another article published about the varieties, and you could see that they are divided in 5 classes, and the artery and the vein could sometimes go one posterior, more anterior, depends the type, subtype, and whatever. Then it means that there is a lot of possibilities. So forget possibilities, forget what the anatomy says, go safe with cannulas and inject in the muscle. So technically, some people inject fillers over the muscle. And if you inject over the muscle, the problem that you can create lumps inside the mouth, or if you inject over the muscle, you can create other lumps. I inject the filler inside the muscle. Remember that inside the muscle, the incidence of having the artery is little, but if you're going with a cannula, is much, much more safe. So for the anterior jaw depressions, for people who have, we can use Belotero volume. As I said, I use 0.5 to 1 cc for these areas. And technically, I can correct deformities, which you need to do surgery or fat grafting or whatever people do not want. We can correct them with 1 cc. You could see the improvement. This is another patient which we corrected her jawline with 1 cc also. This is another patient which we corrected the anterior part of the jawline and the corner of the angle. We put 1 cc to improve them. You see that I can do fillers for every area, for any side, to correct any deformity. For marionette lines, as I said, I use Belotero volume, and I use 0.5 cc's to 1 cc. Remember that this area I always associate with botulinum toxin 4 units for the Dow muscle that we explained before, to elevate the corner of the mouth. And imagine this patient, you see the wrinkling and you see the depressions, how putting some fillers and injecting the Dow muscle could improve. Again, you could see this area is very safe. You usually inject subcutaneously, and the artery and vein is very clean. So there is something that covers them and it's safe, so do not panic. See, this is a submaxillitis and the arteries and veins are very deep over the bone. As you could see, this with the Hayes-Martin maneuver, you can flip them, but they are always deep. Again, for the chin and the parachin area, I would recommend to use Belotero Intense. I like it more because it supports more and it does not, when you press over it, it does not flatters. That's why I like this filler Intense. Intense, I use it for the nose, for lip contouring, for the chin, and for the eyebrows. This is my indication for Belotero Intense. For the rest of the face, I use Belotero Volume, and only for the eyes, I use Belotero Balance. So now you know everything we use about Belotero, where we use Intense in 4 areas, where you use Balance in 1 area around the eyes, and where we use Volume in every area we want in the face. So this is a patient which I use 2 cc of Belotero Intense. It's very important to build height and to build advancement. And this is another patient. One of the biggest problems whenever people inject, first they inject here, technically inject here low, very low, exactly. I have to make the patient to extend his neck and inject very low to give more projection. The same thing in the patient in the case before. This is another patient, you have to inject very low to create changes in the chin and have a very nice. In every one of these, I injected 2 cc's. Chin eats fillers to give support and improvement. Some people come with symmetries and they want to correct. We can correct with fillers with 0.5 to create more asymmetric jawline. Some people come and they have one lower and one higher, and they want to make it both on the same side and same leveling, we can use some fillers to create some camouflage options. I used, as you see, 1.5 cc in one jaw and 0.5 cc in the anterior part of the chin to correct volume asymmetries. Some people come with a depression. In the I use Belotero Intense or Belotero Balance. As you can see, mainly I use more Belotero Balance than Intense. Technically, if it's too deep, I have to use Belotero Volume. I try to correct with the cannula injection going from one side, but also I use blanching technique to really improve that. You could see how it can be improved, and it gives a very nice. I use 0.3 cc's with a cannula in the deep layer and 0.2 cc's with blanching technique, more superficial. So for wrinkles around the mouth, some people come here, they have wrinkles around the mouth. So you're obliged to stop the, I call them the parabuccal wrinkles, with 4 units on every side of the marionette lines to paralyze the down muscle. And I inject, in fact, Belotero Balance for the side. And you could see how injecting Belotero Balance hydrates this area and removes the wrinkles around the mouth. So it gives, for sure, I can really more improve upper part and improve her here, but she didn't want to invest more. So she wanted to invest more in her lower part. Also, this is another patient, which we did fillers and botulinum toxin for the Dow and fillers for all the superficial wrinkling. She has silicone in her face. I can't inject deep. So I was obliged to inject with blanching technique all the wrinkles she has here. And you could see the improvement of the wrinkles. For sure, I can do another session to improve her more, but then the patient, how much he invests, how much we can do for him. For the gummy smile, I've said I start with 2 units, but technically, majority of them, they may require 4 units and on every side. And if 2 units is sufficient, then we don't add. If not, we add 2 units more in the revision. You could see with 2 units, leaving 0.5 centimeter, do not in the middle, how smiles are much better and they are nicer. And for the chin, imagine, I remember posteriorly I said, do not inject high, you have to inject low. And if you are starter, I would recommend to inject a bit more lower, maybe here, and you can inject the 5 units in the center, and you don't inject here for not creating a diffusion to the DLI muscle on both sides. But if you became more experienced, you can go more to inject in these muscles besides, so you can create more diffusion here and more relaxation and better result. As you can see, if you inject toxin, this is the result before and after. Beware in patients who are old, if you inject this area and you forget here to inject the Dow and to inject, and what happens that the patient will have too much wrinkling here and will not like the result. So for masseter, as I said, you have to check the 3 points. For more experience, you can go for a 4-point for reducing the masseter size and creating a slimmer face. Thank you so much. Let's open the questions for lower part of the face and for fillers before we start with complications of fillers and how we deal with fillers. Questions?
Dr. Nabil, when you are going to get, say, a nasolabial fold, at what level do you inject for nasolabial fold?
So I inject subcutaneously.
And the plane for the jawline defining fillers?
Everything on the face I inject subcutaneously. Everything except in one thing. When I contour, I inject more superficially, subcutaneous superficially. And when I do a second thing, when I do nose filler in this side, when I use a needle, and when I use, for whatever reasons, chin advancement with needle for a specific thing, I go with needle, but the rest I do it with cannula. I prefer with cannula, but sometimes I go with a needle for whatever reason, I inject over the bone. But technically, everything is subcutaneously.
Dr. Nabil, can you please emphasize or give some tips for the earlobe filler procedure?
For the earlobe?
Yeah, for the earlobe, yeah.
Yeah, for the earlobe, I prefer to use, if they are too much deflated, I use Belotero volume. And one of the things, the best thing to use is to use a needle better than cannula. It's much harder to go with cannula to deflate this. I think it's nonsense. You can go with needle up here inside, just from here below, and you can fill with Belotero volume and massage well. pretty well, patients are very happy with this, and it's very fundamental in old women's that require, we do them facelifts, we do them many things, and finally they have ear of old women and the face of young women, then they need to rejuvenate these areas. We also can do lasers for these areas to resurface the skin and have a better result.
Can you also emphasize on the angle of the jaw? What angle we should be looking at, and how do we create that angle?
Dr. Arun, Panda, you became so advanced that your questions are very advanced. So very good. So the angle normally, technically between 120 to 130 is what estimated in a woman, and in a man between 120 and 140. If you ask me what is my favorite angle for a woman, is 123. So, but again, some people love 128, some 123 is more defined, like Angelina Jolie's angle, and maybe like Rihanna's angle. If you know Rihanna, the singer, it's like 128. So it depends what more you like more. I like more defined jaw angles in a woman, but it's a bit of what the patient also love. I have patients who come, doctor, I want defined jaws. Some other, no, doctor, no defined jaws. So it's a bit of what they like.
Dr. Nabil, for the whole, when you use fillers for the facelifting procedure, you'll be covering it in the pro-lifting part, or do we ask questions
yes,
here?
I'll be covering in the pro-lifting part after complications. So after complications, I'll be talking about how to make a facelift with fillers. That's the thing that Dr. Rahul have seen it when he was here in Lebanon, and we have seen a lot of patients and how the result is impactful.
Dr. Nabil, is there any role in case of unilateral facial palsy for fillers?
Yes. So there is, this is a very nice question, and I could consider it advanced because they have seen that there is patients who have facial paralysis. You should not only inject them with toxins, you need also to inject fillers to create more tension in the muscle, and there is a biomechanical improvement when relating fillers and toxins in facial paralysis. They have been investigating this, and they have seen that fillers create some volumization effect, which can create the muscle to act differently and to improve or empower the muscle. So this is something that is new, and some international lecturers are talking more about it in advanced lectures. It's called muscle modulation with fillers.
Okay, that's something new.
Yes, it's something. Also, there's a new study. Also, there are some doctors working on it in Spain. They are seeing that people who inject toxins, they become much happier emotionally. And there is something that they have seen that injecting some types of fillers in the face, toxins in the face, mainly the dow muscle, they have seen that people feel that there is less tension of going sad, and they become acting more happily. And we are investigating this, and it's related, toxin related to emotions, and something new. Maybe we could see about this more in the future.
I think we should go with the complications.
Yes. Okay. So let's start complications. So for complications, I would really, first of all, I would say for all these participants that are with us, I mean, we have been for maybe 2 hours and a half or whatever. I don't know exactly when we started. And this is, if you're still there, that means that it interests you. And the people who quit it for several reasons, maybe, but the people who are still there, that this is your domain and you're really interested to be a facial plastic or cosmetic medicine, whatever. So let's go to the most important part, which is update protocols of complication. So I can tell you that I have injected a lot of fillers, and injecting with me safety, but being on the safest side, knowing anatomy, dissecting with cannula, having a lot of experience, published about facial complications, studied about facial complications, did everything to prevent complications. I have a filler emergency kit. I'm very well prepared, and so much prepared. I had 1 syringe in my life. And as you see, this is per years. Every 2 is per year. Every 2 is per year. This is first year. This is second year. This is third year. And in third year, see, like in the mid-finals, I had one case. So this is something that have taught me too much, that also in the best hands and knowing a lot of science and anatomy you can have. But thanks God, I acted very well and I was prepared for this because I had a filler emergency kit and I solved the complication at time. And let me explain what are the complications that we can have. We can have Tyndall effect or overcorrection or edema. We can have nodules or granulomas. We can have necrosis of the skin, and we can have blindness. Okay, so technically, as you know, and I'm one of the, maybe considered in MERS, one of the most injectors using this product, because I'm exclusive to this product. And in Middle East, we do a lot of fillers. And as you could see, I never had any complication with Belotero except necrosis in an area that it didn't happen to see necrosis. I had a blockage, I could say, but never had a necrosis. But I treated a lot of necrosis of friends who have derived to my clinic. I've treated nodules and I treated Tyndalls from others. And I can tell you, so if you had any of these complications, the first thing that you need is to read all the protocols worldwide. And then one day I decided, okay, I want to be prepared for this. I want to read all the protocols worldwide. So I read all, and I've seen that there's a lot of problems in the protocols. Some are wrong, some are not precise, some they don't tell you the exact value, some they say to use something that it's then contraindicated. And then I decided to write an article, which I published in 2019 with 2 Indian doctors who were doing a fellowship here, which is Deepak Khanna and Karti Punja, who came to Lebanon to visit me. And we published an article about filler emergency kit and the new protocol. So we will talk about this. So this is the article that has been published in 2019. And I've discovered that there's an old protocol and there's a new protocol. And we should, all the doctors, know the new protocol and avoid talking and in conferences about all protocols for complications. And I can tell you that in 2020, January, I was in a conference, and it was a very important conference. And there was a speaker, a very important speaker. He was talking about complication, and he still was discussing all protocol. And I said, that's unacceptable. So please, doctors, anyone who want to talk about something, please make a bibliographic review and then discuss. If you give lectures 5 years ago, doesn't mean that the lecture is the same. You have to advance, you have to find, if you discover. So also, whenever you know too much, it's better to go learn from others who know more, or maybe they know less, but for this domain, because they made a bibliographic review, they know more than you. And then you learn from them and you integrate it to your slides. Again, for hyaluronic acid fillers, first thing is to know that hyaluronidase is not permitted for cosmetic use. It's an off-label prescription. So then, if you are in a legal way, you want to protect yourself, your patients should sign a consent before they do the filler that in case they don't like the filler, they can use hyaluronidase and it's an off-label prescription. So in my consent, it's written because you can't use off-label prescription, except it's allowed to seek the welfare of the patient and respect. But if someone want to really go legally with you, he can really penetrate you from here. So again, how much hyaluronic acid do I need to dilute? So there is a study published in 2014. For every 0.2 cc's of hyaluronic acid, it requires more than 30 units. More than 20 is sufficient. We recommend 30 units. And depends which filler you use. Some fillers dilute easier, some fillers dilute faster. And this is something that to take into consideration. Then if a patient comes, you have to assess how much filler she has excess. Okay, she has maybe 0.4. So then you multiply 0.4 times 2 because you need 30 units, then you give 60 units. Technically, if you don't want to make a headache for your mind, you can start with 100 units to dilute. Remember something that hyaluronic acid does not only dilute fillers, also dilute your own hyaluronic acid. So people, whenever you dilute them, they will exacerbate the problem that they have. So remember that to explain them that they may require then later to correct some of the deformity. So we use between 50 to 100 units, and there is Tyndall effect. I never had Tyndall effect, and Tyndall effect is when you inject the filler superficially, it becomes the appearing of bluish. And this is because the only product in the market that cannot create Tyndall effect is Belotero. The rest has because of their formulation. And Tyndall effect gives a bluish effect under the skin. Maybe in India, skin are darker skins, you can't see the bluish, but in our countries, people are white skins and you can see the bluish. So that's why I don't use other products except Belotero. And overcorrection, it can happen with one. Is you inject very well and very precise and very everything, and you know that you injected very little quantity, but the patient absorbed more water for whatever reasons, and it creates an overcorrection. Then you need to eliminate a bit. As you see, if you have overcorrection, you can reduce. Technically, it's very hard to know how much days you need to use. Technically, it's much more experience to put less and go more and more, because for not creating too much defection. Also, you have to know that days sometimes need to be in the same plane of the hyaluronic acid, whatever some other studies say that days diffuses well. This is yes and this is no. I don't know how to explain it well. Other options, sometimes that days normally you massage it, it can diffuse. It really diffuses to the lateral side, so it can eat fillers from the lateral sides if you don't want to decorrect these areas. Remember something that days is hell pain. Patients feel pain, then you have to tell them that it's a burning sensation and they can tolerate it. So some people have chronic eyelid edema, and you do fillers for them and they create, I never had any case of this, but it's published, chronic eyelid edema. You need to dilute the fillers to correct this. And this chronic eyelid edema, it doesn't appear exactly after the filler. It appears several years after the filler, they start having eyelid edema. Maybe I can consider that when the filler is injected, could be the problem, water retention in these areas, because I can tell you something, that fillers do not last between 6 months to 12 months. Some areas, filler lasts for years, yes, for years. I've done surgeries in patients which I put fillers on them, and after 2 years, 3 years, I open the eye, I see the filler. I did fillers for people in their noses, and I do next level surgeries, and I can find the filler. So filler stays much more time in several areas. Maybe we need to more study this. Maybe we need to know more about this. Maybe we have to find a study and do something worldwide. And I've discussed this, but it's not easy. But fillers, many areas stay for more longer. And maybe we can create a discussion at a later stage. But this is something that to take into consideration. If we have nodules and inflammatory nodules, we can use antibiotics. And we can use days to dilute the nodule, and antibiotics if there is inflammation nodules. Sometimes you're required to give several times. Nodules could appear superficially. Also, other areas, granulomas. And granulomas, as you could see, they are non-urgent situation with bad products or with bad fillers, or infected or injected over bad fillers, or injected over silicone, or any other problems. There is no option except sometimes doing surgery, giving cortisone. And if you do surgery, you can create scars, and scars can create depression. Technically, nowadays, fillers are clean, good brands. There are still bad brands in the market, but going with good brands avoid you having these types. And if you do a very nice cleaning before injection, it's important. So if in case you create nodules because of the fillers are of low quality, sometimes there's no option except doing surgery to eliminate them. And the problem of fillers is not the granulomas, it's not the infection, is the biofilm. If you don't know what's biofilm, biofilm is, imagine that you have a filler here. So the bacteria goes and lives inside the filler, and it starts multiplicating inside the filler, and it like a shield for it. So the blood vessels and lymphocytes and macrophages cannot enter the filler, so they stay around the filler, and the bacteria secretes bacteria. And this is very hard, and sometimes it's very hard to solve. One patient came to me having biofilm. I could tell you that it took me more than 2 years to control her infection. Very hard. She had abscesses, she had whatever. So technically, it's better not to accept these patients and try to derive them to another one, because it can smug your energy a lot because of these granulomas and biofilms. Technically, granulomas and fillers is because of injected volume, too much volume in the area, or because you have repeated injections and impurities of the filler. or because of it's a bad filler. So this is something to really take into consideration and really take care to use good brands. So what about necrosis and blindness? So necrosis and blindness, technically, maybe nodules, granulomas, whatever you can see, or maybe you can less see. Overcorrection, you can mainly see too much. But what really little you can see is maybe necrosis and blindness. And you have really had to be prepared for this. Please, everyone who is hearing me today, if you are not qualified, if you don't know the subject well, if you don't have experience, if you didn't do any fellowship, please do not start injecting fillers. Doesn't mean if you hear a lecture that you know how to do fillers. Fillers is something serious. And if you have a problem and you don't know how to solve the problem, then voila, what do? Then your career is jacked forever. So jump only whenever you are prepared. First, for everyone who has joined me here in a fellowship, I've seen that they never started, they come fresher, they learn the science, they learn everything, and then they jump. Then you are prepared, then you can reach a good expectation. So for vascular occlusion, see what happens. For vascular occlusion, so before Seema asked me if I use anesthesia. So sometimes if you use anesthesia to block the lips or to block any area, you can really avoid the pain effect, which is an alarm to know. If the patient, you injected fillers and the patient starts with a lot of pain, that means there's something wrong there. The second thing, you start seeing blanching, immediate blanching. So if you injected anesthesia with epinephrine, it can give you a fake and not an alarm you. And this is something that you have to avoid, injecting epinephrine in the anesthesia. And for these patients, try only anesthesia with the epinephrine. So because blanching means something, a problem happening in the skin. This happens in seconds, Then you will start having slow refill. You press over the skin and fill up with vessels. This is an indication that, hey doctor, stop, you have to use hyaluronidase. And from 1 to 10 minutes, imagine 1 to 10 minutes, livido phase starts. So when livido phase starts, then you have to jump quickly for the emergency kit and activate the alarm of filler emergency kit to start with. For whatever reason, if you don't start putting anything here, then it will start giving bluish and gray. And beware for young doctors who doesn't have too much experience, they could think that it's an hematoma, it's a bruise, and hematoma bruise does not have before libido phase, does not have slow capillary, it's not drawn in very well circumstance, then it means something is a blockage. But if you don't act or do something here, then you will have a blister formation, you can have a scar, then you need to treat the scar, repair hyperbaric oxygen, and this. And please, you don't want our patients to live with this. Some people have lost their noses. Some people, they have permanent scars in their faces for this. And this was my patient, she did a rhinoplasty in another country, and she came to me and she didn't like her nose. And she was my patient, but my price is overpriced for her. She decided, okay, to go for another place around us, which is cheaper, and she can do the nose. And she did the nose. And she came at 7 months. She said, doctor, can you do some fillers retouch for my nose? I said, yeah, why not? So I went with a cannula. I dissected and I put the filler. And directly when I put the filler, I found that in a minute, I've seen that there is livido phase. So in a minute, so I stopped. I injected very little and I stopped. So I stopped and I told my nurse, please let her stay in the room. We have a special room for the patients, and leave her there for 5 minutes and let me see her back. At that 5 minutes, I went, slow capillary refill, and bluish happens, and I took the picture. So I knew that there was a complication. So I told her, okay, let's prepare her. I have to dilute the filler. I have to stop this. So here is a problem. Where is the blockage? So imagine that the blockage is in the nose, and I dilute the filler, and I put very little dilution of hyaluronidase. The filler will become smaller, and maybe it goes to the eye and it blocks the eye. So I started first to confirm if there is any blockage also in the head. So in the head, there is also that means that blocking area is going from up, it's going something up higher also. So something that it can really refers me to the location in non-100% degree. So something that I will discuss later, how we put, and something is very important. This was the old protocol. The old protocol was saying inject directly into the area where circulation of blood supply appears to be reduced to 100 to 600 units, use warm compresses, use nitroglycerin, and all this is unacceptable. You can't use nitroglycerin and warm compresses because you will do vasodilatation. And if you do vasodilation, what will happen to the hyaluronic acid impacted in the nose will go more to the eye, and it will go to smaller vessels and can aggravate and exacerbate my problem. And if I use only 200 units in the area, and what happens to the around? How can I know if the hyaluronic acid travels there? I could not dilute it. So I need to inject also in other areas. And then aspirin, I have to have aspirin in the clinic. What about if I don't have aspirin? I will send the patient or the family to get him aspirin from a pharmacy? No, no, no. You should be prepared in your clinic. Then that's why you have to have a filler emergency kit. Then you have to have antibiotic, cortisone, and maybe you follow up daily, and maybe you have to do hyperbaric oxygen if the skin doesn't heal well. So the real protocol is this one. So we have to inject 500 units per area per hour. Per area, no, not in the location of the blockage. So I will be injecting here, 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 around all the area. And I'll be injecting 500 units. And if it's affected 2 areas, and 2 areas means like nose and nasolabial, then in every area I have to inject 500 units. And if it's affected in the nose, the protocol is to start 900 units. So you can't say that, okay, I have only 1 bottle of urinidase in the clinic of 150 units. If you have only 1 bottle of 150 units, you have to have 10 minimum. If you have 1,500 units, then you can have 2. Then you have to be really prepared for an emergency. It's as if you have a cardiac disease and you don't have this electric shock. Then you have to have aspirin. You give 81 milligrams under for daily use, but at the moment you give 325 milligrams under the tongue, and you give ciprofloxacin and prednisolone, and you do follow up daily and care wound in case the skin. So in an article published in 2013, they have seen that the risky areas are the nasolabial, the nose, the glavella, and these are the publications. There are many more than these, but these are only published. And for blindness, I could ask you, for blindness, this was the old protocol. Use 300 to 800 units and all the rest of medication. And the protocol has changed. This is an emergency situation. An emergency situation means that you are the only one who can treat this. So if you can't treat this, please do not start doing fillers. Because if you have any blindness, then you are not prepared to the treatment. So for blindness, the patient will directly tell you, oh, doctor, I can't see. And let me tell you something, what happened to me. One day I was doing a surgery for a patient. I injected lidocaine with epinephrine in the infraorbital. And till now, I didn't injected him any filler, but I was planning also to inject him a filler. And when I injected the infraorbital, because he didn't want to feel any pain, but this is when I started at my first starters. That's why I'm not anymore using anesthesia with fillers. I make a small hole and I can go with the needle. With a cannula is barely tolerable, and it's not painless. It's not painful, I mean. And technically what happened with this patient, I put local anesthesia in the infraorbital. And in 5 minutes, the patient told me, doctor, I can't see from my eye. I said, how is this? I didn't do anything. I didn't put fillers. I didn't put anything. How you can see? This is impossible. I thought that the patient was doing for me a joke, or I thought the patient is a special patient and he's doing something strange. Maybe I should not do nothing for him. Doctor, I can't see from my eye. Doctor, I can't see from my eye. I said, impossible. So what happened to him, to the patient, after this, I reviewed the literature, and it seems that sometimes if you inject the infraorbital anesthesia, vasoconstriction of this bundle, artery and nerve, creates blindness, temporal blindness, and it's solved by waiting. Imagine how I was scared at that time. Thanks God that I was still so young that normally when I'm young, you think that patients are lying on you. and you don't know a lot of science. But if I knew a lot of science, I could be more calmer and maybe know that it has to wait. But whatever it is, it happens a blindness. I felt what does the patient says, I don't see with my eye. I felt the sensation of how you could feel risk. But imagine with fillers, the patient, you inject fillers and the patient, I can't see. You have to inject 800 units, which is around 4 to 5 milliliters of hyaluronic acid. You have to dilute it correctly. You can't add more because it creates pressure. You have to inject retrobulbar, very slow injection, and I will tell you why later, infratemporal, and with a cannula of 25 gauge. You should do an eye massage, and you have to have timolol drops to increase pressure, to reduce pressure, and put him a mannitol IV to reduce pressure. The nurse should act quickly. And then put aspirin, 325 milligram under the tongue. You can use acetaminophen also to reduce pressure, cortisone also, and then you have 10 minutes to send him to an ophthalmologist to do the retrobulbar slow injection infratemporal of hyaluronidase if you don't know how to do it. And if you send it, you have less than 10 minutes to act. So then you don't have time to send it to an ophthalmologist. Sometimes if it does CNS, you have to do a brain MRI and send it to a neurologist. And sometimes it can create blockage in other areas, mainly in body filler surgeries. You have to do fibrinolysis. So if it happens, what happens that the filler comes, imagine you're injecting in the glabella or in the nasolabial, the filler travels and it will go back and it will block the central retina artery, and blindness happens. That's why it's very important that in 2015, they published 92 cases published of blindness. And as you see in 2019, we had 190 cases published, and maybe there are other cases not published. And the risky areas are the glabella area and the nose and the nasolabial and the forehead. Then imagine that you can have from every area a complication. So imagine that's why you have to really need to know how to do the So how we do this, I will teach you. So you have the eye, and they have studied where is the area that is safe to go with the cannula. And the area that's safe to go with the cannula is the infra area, which is here at this side. It's safe because if you go from up, the problem there is the vein, and you can perforate veins and create hematoma, internal hematoma. So the trick is to go with the cannula, and I will explain. You go with the cannula and you hit the bone, and the bone, since it's conic, it will deflate or it change the movement of the cannula till the center of the optic nerve. And there, when you reach at 2.5 centimeter, you have to inject very slow. And why? Because they made this a study, and they've seen that whenever you inject slow, then the filler will diffuse better. The hyaluronidase will diffuse better. And if you inject fast, there is less diffusion of hyaluronidase. And that's why you have to inject slowly. So this is very easy. You put the finger, you go inside the bone, and technically the bone will derive to go to the median. So this is a video you could see. Let me go back. This is a video that you could see that I feel the periorbit. I go with the needle. I go straight, hit the bone. I'm hitting now the bone, and I push hitting the bone, and the needle will tend to go more medially. And when I'm at 2.5 centimeter, I'm there. I start I aspirate to see if I'm in any artery or anything, and I start injecting the hyaluronidase. As you could see, this is very important. This is how we inject hyaluronidase in the retrobulbar injection. Okay, so the eye could have mydriasis from the pressure, could whatever. This is something normal, and this is something that we can really see. And one of the things, other things which are important, is very important to really have a firm understanding of the anatomy. Aspirate before injection. Inject small quantities, moving the tip slowly, minimal pressure. Dissect with the cannula. Try to consider to shift cannulas, which is much more safer. Caution in previous surgical areas or scars. And what happened with my patients that she had rhinoplasty done? The patient, she had rhinoplasty done. What happened to her is that she had scars, and there are changes in the anatomy, and maybe the cannulas dissected well, but I was in any area that I created maybe pressure, or I perforated, or I created venous congestion, which I can't know 100%. But this is something that I knew how to solve. I acted quickly and I solved her problem before she can have a big problem. So firm knowledge, early diagnose, knowing the steps, be prepared. You should have an emergency filler kit and immediate treatment. Do not think twice. It's better to eliminate the filler and lose money than have a complication for the patient and kill it forever. And for filler emergency kit, you can really download the article or read the article, and you can find it in the American Journal of Cosmetic Surgery. And it's called the hyaluronic acid filler emergency kit, which you can learn about the steps and everything regarding this and what you need to have in the kit. And everything is published in the article. You can read it, you can build this kit in your clinic, and you can be prepared for any cosmetic event or any complication. So thank you so much. And we will open the questions for anyone who would really like to ask any question regarding complications.
Rahul, is there any questions?
Dr. Nabil, how do you decide between fillers and microfat?
So the difference between fillers and microfat is that fillers, what they do is exactly, it's more natural. It's very good indicated for young patients who lose a lot of fat and do sports a lot. I would recommend to use hyaluronic acid. For people who are stable in weight, they want to do something natural, I would decide to go with microfat. But both things I like, both things I do. So I would recommend more in someone as a starter to start with fillers, and then when he get more advanced knowledge, he can start with fat. Because injecting fillers and fat, they are similar, but not too much similar. But complications in fat grafting can kill you. Complications in fillers can let you solve them at a young age. As a starter, start with fillers, and then you jump to fat grafting.
Seema? Rahul, you have one more?
Yeah, just one more question.
Yeah, quick.
Nabil, you were speaking about that there's a confusion between how long do the fillers stay. Some say 1 year, 6 months, some say they say for 2-3 years. I came across a recent webinar where the speaker said that they've done MRI studies and that the filler stays probably for 10 years or 15 years. It just merely what you call migrates or diffuses to a different location. Is that your take, or you have a different take?
So I don't think fillers, good fillers, which are hyaluronic acid, if they are from good brands that Jovadan, Belotero, or Rustin, I don't think they will diffuse. But if they will stay more, I could say yes. And that's why I've seen in a lot of patients, I can tell you, I have a patient when she had a rhinoplasty. She had a very little minor change. I put filler on her, and I can tell you 3 years later, the correction is stay there. I don't know what happened, collagen production, improvement, still there, whatever. Some areas, they still there for much more time. We've been discussing this a lot of key opinion leaders worldwide. We don't have answers till now, but something that we can consider, and it's always on our benefit, because something that corrects and the patient should not pay again, something that is happy the patient for it.
Dr. Nabil,
Seema? Go ahead.
Yeah. So could you have any exact anatomical landmark for doing the retrobulbar injection of the hyaluronidase in case something goes wrong?
Yes. So if you want to really learn this, Johnny from the Netherlands, he always organizes every year a course. It's expensive course, but it's worthwhile to do it. I've learned to do this with anesthesiologist. So it's very easy. If you go to any department of anesthesia, they do retrobulbar injection for anesthesia of the eye. So if you really want to train, and if some of your friends are good anesthesiologists and they do it, in worldwide they do this procedure, and you can tell them, hey, I want to learn this. If there is any patient there, if you can teach me, and I will start doing this. And this is how I learn. It's very easy. It seems hard, but technically it's easy. But you need to try it to feel it easy, like everything in life. You go here direct, you put some anesthesia in the anterior part, you feel the orbit of the rim, and you go with the needle. And you go with the needle straight. Straight, since the eye is conic, the needle will hit the bone. And then you continue, and the needle will will start shifting more medial. You start hitting the bone hole and the needle goes medial. And when you feel that you went like 2.5 centimeters, which is along the length of the needle, then there you have to leave the filler. I mean, this is the safe area. There is nothing there to perforate. There is no artery there to perforate. There is nothing that you can create a complication. You're going in a safe fat pad area. So if you do like this, it's safe. So I've trained myself not going to this course. I've trained myself doing it with an anesthesiologist who does retrobulbar anesthesia injections, which you can really search. There's always procedures in the hospital, and big hospitals they do. Hey, call me when you have anyone. I want to try it in a patient.
Thank you.
Okay, can we take the last question from Seema?
Can I take a question? One last question.
Is there any question with Seema, Rahul? Let's wait. Let's listen from Seema. Okay, Rahul, go ahead with the last question. Yeah, I think.
Dr. Nabil, fillers when you inject into the face, how long does it take to have the shape memory to take place? How long do we have to manipulate it?
I mean, you should not manipulate the filler. You move it, you massage it, you leave it, and then it will stay there. It requires 2 weeks for final result to reach. So I think you should tell the patient to wait for 2 weeks so you can assess and decide if you need to add more or less.
So is it like when you do a nose filler, is it better to do the fillers and then put steri strips to maintain the shape, or you just send the patient directly?
I put steri strips for the patient not to maintain the filler. So he cannot touch or do this or move the filler. Just only for that reason I put him, so he knows that there is something there, do not touch, till the filler adapts well.
Thank you.
Okay, thank you. Thank you, Dr. Nabil. It was a great, interesting session, and I'm sure all our participants learned a lot. This is a new beginning. We'll see you soon more, and we'll also hope to see you at our next annual meeting. So the co-host and Dr. Nabil, can we meet for the debriefing? We'll share the meeting ID.
Dr. Pritam, can Dr. Nabil just discuss about the pro lifting? That's the whole face thing.
Rahul, because I think there are a lot of people started leaving there when we said the last question. So I think we'll do another session. We'll do another session anyway with FAT soon. We'll plan another. So we'll meet up in the debriefing. The meeting ID will be different. Okay. Dr. Nabil?
Yes. Yeah. Thank you so much.
There will be different. Thank you so much. And there will be a separate meeting ID on which we'll all meet up for debriefing. And to all participants, thank you for being part of this webinar. I'm sure you would want to listen more from Dr. Nabil. We'll soon definitely organize one more from him. Our next webinar is on the 20th of May. That's on the TMJ series. You will have Gary with us, joining us live. Kanan, yes, Kanan, you wanted to say something?
Yeah. No, nothing. Thank you, Dr. Nabil. And anyway, you have highlighted about the TMJ webinar. I just thought if you wanted to mention.
Thank you.
Yeah,
so we'll meet
fine.
with a new meeting.
Dr. Nabil.
Thank you all.
Thank you.
Thank you.
Bye.
Thank you, Dr. Nabil.